Good morning, everyone. I'm Adil El Maftouhi. I'm from Switzerland and Paris, and today I'm going to talk about the different abilities of Solix platform for anterior to posterior segment. So Solix platform is a spectral domain with a high sensitive camera and a rate of 128 scans per second with a very good axial resolution of 5 micron. The possibility to obtain a very large and wide scan of 16 millimeters up to 6 millimeters, and very nice OCT angiography with algorithm SADA with a scan of 3 millimeters up to 12 millimeters, and the possibility to have a composite. And they are also associated with a fundus camera of 45 degrees. So we can make some picture of optic nerve, anterior segment imaging associated with OCT scan and OCT angiography. The last evolution of the OCT is a full-range technology using a part of mirror image to increase the depth of the scan up to 6 millimeters. It's very nice to improve the scan of myopic patient, like in this case of staphyloma. And you can also better analyze the vitreous body with this scan of 16 millimeters and the depth of the 6 millimeters. And look here as compared to the conventional OCT with 3 millimeters depth. You can very well identify the premacular bursa and the Marteggiani area with this large scan. Look, in this case of coloboma, you observe a very large premacular bursa with a full range retina. You can have a multimodal approach with en-face OCT. And look here, in en-face OCT, you can highlight it, the premacular bursa and the Marteggiani area with the en-face OCT of 12 millimeters. It's always difficult to analyze a dynamic tissue with a static approach. And I try to give some dynamic approach to associate several B-scans. And look here, we know with age there is a connection between the premacular bursa and Marteggiani area. And look here, another case of beginning posterior vitreal detachment with full range retina. And we can observe in the beginning PVD the connection with the premacular bursa and the posterior cortex vitreous. And look, another case with a dynamic approach, and you can observe the different motion of the vitreous liquefaction of the posterior cortex vitreous, the connection with the premacular bursa, and you can also see the motion of the pre-fiber just here within the vitreous, in this case of beginning PVD. And look, another case with a full range retina with a very small foveal fraction. And look here, we can observe a reaction of the photoreceptor layer. With this large scan, we can analyze the first sign of PVD. And look here, you can observe in the area of arcade a small detachment of the vitreous in patient of 40 years old. And look here, patient with high myopia, with very large staphylomas, with a full range retina. It's completely easy to scan this kind of patient as compared with a conventional OCT when you have a disturbance of a small depth. And look here, a dome-shaped macula, and you can also analyze the peripheral area with this large scan. And look, in this case, this is the retinal peripheral schisis, and you can also analyze this bullous aspect, and also sometimes some retinal tears. It's really easy now with this very large scan. And look here, the hole with this micro retinal tear detachment. You can also analyze some other lesions like the toxoplasma chorioretinitis, and you can observe also the micro point due to the inflammation associated. You can make some very screening and very quick B-scan shot with a wellness scan pattern. You can have some different B-scan, retinal thickness, and GCC analysis in a very quick shot of 5 seconds. And look here, this is a GCC mapping. The very large retinal thickness, and you can move through this area of 10-12 millimeters to make a very quick screening of the retina. You can also associate OCT, angiography, and vessel density with this scan. OCT angiography with the SAADA is the first OCT angiography of the market, with a very good contrast between the decorrelation and the background. But the main problem in OCT angiography is to have a very high definition and a quick scan. And now with the Solix, we improve the resolution of the cube with several B-scan additional. Like in this case, a cube of 3x3 with 300 B-scan, a cube of 6x6 with 512 B-scan with scan density of 12 micron. The scan density is the space between each B-scan. A cube of 9x9 and a cube of 12x12. And you can see here, we observe the decorrelation signal of this CNV on each cube due to the high resolution. And in OCT angiography, the good thing is to have a good compromise between the high resolution and the time. And you can observe in OCT angiography with the Solix, the time is included between 4 seconds and 50 seconds. And you can identify the several vascular plexus according to the histology, capillaries within the RNFL, superficial plexus capillaries, intermedial deep plexus, and the deep plexus capillaries. And look here, with the increase of the resolution within the cube, we can observe the decorrelation signal of CNV even in a large cube of 12x12. And here there is a CNV decorrelation signal with a cube of 12 by 12. The last improvement in OCT angiography is the ability to put off the projection artifact due to the superficial vessel on the deep plexus and on the complex and the choriocapillaries to better isolate the decorrelation of CNV. And look here with and no projection artifact removal. And one of the specificity of Optovue is the part is in 3 dimensions as to compare with the competition where the PAR is just 2 dimensions. And PAR is mandatory to analyze the deep plexus complex density to put off this projection, like in this case of diabetic retinopathy, and you can better analyze the deep complex plexus density. And we improve the visualization also of the choriocapillaries with this software due to the genius idea of David Walk, one of the co-inventors of the OCT. And look, with the PAR, you can better identify, with no manipulation, the decorrelation signal of the CNV, in this case of the CNV type 2. And look here, its outer nuclear layer is very easy to identify this decorrelation signal compared to the OCT angiography signal on the overlay on the biscuit. And look, with the PAR, you can better identify the decorrelation signal, and you can quantify the flow surface very precisely. And look here, this is a movie of CNV follow-up with a Solix platform, and you can observe the effect of intravisual injection just to the very recent part of the CNV. You can observe the maturation of the main part of the CNV. PAR allows also to detect incipient CNV in very early time. And look here, in this patient, there is a micro PED. And look, with the PAR, you can highlight this very small decoration due to the incipient CNV. And you can follow the patient 2 years after the CNV in growth, but no fluid until 3 years after. Another last evolution of the Solix is the segmentation. The segmentation now is trained by deep learning, and it's you observe a better analysis of PED, especially with the improved segmentation of the Brooks membrane and RPE. You can also have the possibility to correct the segmentation of, as is in this case of a PED with a surface detachment. And you can just change one line to propagate the correction of the segmentation. And look here, with the correction, we observe the CNV within the PED. And look here, it was without deep learning, and with deep learning, in case of atrophy, there is a better segmentation of the Brooks membrane and better segmentation of PED. That's one of the limits in OCT angiography in the beginning. It was the problem of the segmentation. And now with deep learning, we improve this, and you can also detect the CNV decorrelation with all CNV. And look here, the very native segmentation without any manipulation. Another comparison, no PAR, with PAR, with the improve the segmentation, you improve the visualization of the CNV. Another comparison with the XR120 and the Solix. This is the same patient. And look here, with the Solix, you can highlight the presence of the CNV within the PED on these different cases. So the segmentation improve with PAR, improves the visualization of CNV within the PED. Already sees that. Another cases about the new pattern of 3D volume rendering. Its ability to have a 3D approach of the CNV. This is a case of a best disease, complicated with CNV. And look here, you have the possibility to have the 3D. And 3D is very useful to appreciate the shape of the CNV. Because in OCT angiography, you have just a 2D approach. And if you want to appreciate the shape of the lesion, 3D is mandatory. And look here, another case of CNV, complicated MAC10, and look here, the correlation with the 3D approach, and you observe the CNV within the retina and the bad connection between the superficial plexus with the capillary dilation and the connection with the CNV. And this OCT angiography pattern improve also the contrast, but it's also available for 3 millimeters. And look here, before and after intravitreal injection with a 3D approach, and you can observe a very good vasoconstriction of the CNV after the treatment. Okay. Another case here about myopic patient. Sorry, I have a problem, and you can observe the architecture of the CNV. OCT angiography of the Solix and of the XR is one of the best of the market. Why? Because we have the best contrast between the decorrelation signal and the background. And the competition use the full signal of OCT, and there is many noise on the image, and you have to improve the image with the Gaussian filters. And look, when you want to see some very slight detail, like in this case of the CNV type tree. And look here, wait, the video, and look here, the connection between the capillaries dilation of the CNV. And look here, with the 3 millimeters, you can highlight this very small detail of the CNV with a very, very good contrast. We finish the video, and look, you can make zoom, and you don't lose detail. We have the possibility to have a very good quantification for the CNV is the flow surface analysis. The flow surface analysis can quantify the recurrence of the CNV and the increase of the vessel density within the main part of the CNV. And look, in this case, before and after you observe the increase of the flow surface in correlation with a recurrent CNV. In other cases, with the flow surface approach, and you have to delimit manually the surface of the vessel to analyze the decorrelation signal. Another case of very incipient CNV with a little fluid, and before and after you observe an increase of the flow surface due to the densification of the anastomosis arcade. And with a very good contrast appearance of the CNV, you can manage and follow up a CNV and look, in this case, of the CNV patient during a pharmacology study. You observe the increased surface of the membrane, but this patient keep always 20/20 visual acuity. So flow surface in OCT angiography is not correlated with the visual acuity, especially in the CNV type 1. But look here, with a very nice decorrelation signal, you can observe very well and highlighted the evolution of this CNV appearance. The main advantage of OCT angiography is the ability to obtain early detection of the CNV before the first sign of exudation. In this case, you observe a drusen appearance with no real fluid or edema, but there exists already a CNV appearance with a very good contrast with the Solix Optovue. And now you have a very nice screening of drusen with a B-scan, OCT angiography, and also en-face OCT. You have always to consider en-face OCT when you want to make a diagnosis with OCT angiography. You look OCT angiography overlay with a B-scan, you compare with en-face OCT and the B-scan. You can make some early detection in a pseudo-vitelliform deposit. In this case, there is no decorrelation signal, no CNV. Another case, we observe fragmentation few months later. This is a B-scan. You have a drusen appearance, a slight thickening of the Brooks membrane, no fluid, a very slight FIPED, and look, there is a CNV. And you can follow the patient, and look here, this is a 3 years follow-up. As we have a very nice contrast OCT, I can make this movie to compare the CNV, and you can quantify the flow surface to prove we can contain the evolution of this membrane. CNV is not always on MD, and we have to analyze every time the corridor. And with the en-face OCT, embedded in your OCT angiography pattern of 9 of 12 results, you can analyze the dilation of the choroid and the pachychoroid spectrum. Sometimes you have a bad response of anti-VEGF in some patient, probably due of the CNV in case of pachychoroid, and sometimes you have to use a B therapy with PDT to treat this patient. And look here, in case of pachychoroid, in your right eye, there is a dilation of the choroid, easily highlighted by the cube of 12 by 12. Okay. Another spectrum of the pachychoroid is a small deposit with a pachychoroid pigment epitheliopathy. And look here, there is a good correlation between the en-face OCT and the choroid topography. And look, we observe a small deposit in the same area of choroidal dilation. Okay? And look here, you can observe the thinning of choriocapillaris in the same location of your deposit, explaining the pachychoroid mechanism. Okay? And look here, with a cube of OCT angiography, 12 by 12. Okay? We observe the retinal thickness, and look here, we observe the thinning of the retina. Choroidal topography, we observe a dilation of the choroidal vessels. And here, the correlation with the en-face OCT and V-scan. That's why I said it's a multimodal approach, and you have to use all the parameters of your cube. And now you can make just one cube to make a diagnosis. Okay? And this is the case of CNV in pachychoroid. And look here, the CNV. You can see, you can observe the serous detachment, and there's some cystoid edema. Very nice the correlation of the CNV. And look here, just with the retinal cube, for a second, we observe choroidal dilation. Okay? So you have CNV, pachychoroid is a CNV in case of pachychoroid, because we check if there is drusen or not drusen, but if you don't have drusen on the other eyes, it's completely CNV in the pachychoroid. Okay? And it's a game changer for the treatment. OCT angiography in diabetic retinopathy. We know also the advantage of OCT angiography to detect the small capillaries dropout, especially in the superficial plexus. And you can observe the dilation and the micro aneurysm, especially in the deep plexus. In OCT angiography, the main aim is to analyze the area capillaries dropout in the peripheral area. And look here, in this case, you can highlight the pre-retinal new vessel in case of subretinal hemorrhage, masking the leakage of the Fusarian angiography due to the motion of the hemorrhage. Another case of the pre-retinal new vessels. And look here with a composite of 4 cube of 9 by 9, and you can observe the capillaries dropout in the peripheral area. And look here in vitreous location, we observe the presence of pre-retinal new vessels. And look here, the pre-retinal new vessels, here with a 3D rendering, and you observe the pre-retinal new vessel complicated this diabetic retinopathy. You have several quantification of the surface of the phase to analyze the trend analysis. And look here, this is a movie of 5 years follow-up diabetic retinopathy of type 1. You can observe the capillaries remodeling. We know that the visual acuity is correlated by the vessel density of the deep plexus. and the patient still conserve a very good vision of 0.8. And trend analysis is mandatory to compare this picture, because we have sometimes some reflectivity changes due to opacity media, and you have to use probability to analyze the evolution. Because quality of the OCTA signal may vary depending on the quality of the acquisition, and this statistical trend is necessary to validate certain changes in vascular density sensitivity. But we need a standardization of the different quantification of capillaries density between each OCT. And look here, in case of BRVO, you can analyze also vessel density and area surface of the capillaries dropout, and you can use a very large scan to analyze this area of capillaries dropout in OCT angiography, and you can make a composite. You can use OCT angiography for the inflammatory disease. Look here, the case of acute multifocal placoid pigmented encephalopathy, and you can observe, this is a cube of 12 by 12, the choroidal dropout within the choriocapillaries due to this disease. You can follow up this patient 1 month after, without treatment. You observe the resolution of this lesion as compared to the ICG. That's why we have to use all parameters of the OCT angiography and en face OCT. And look another case with one cube and several multimodalities. OCT angiography 9 by 9. Look here, the deep plexus, outer nuclear layer. There is no sign of CMV. Here in the choriocapillaries, there is a small defect due to the atrophy. And look here with the en face OCT. Is reticular dystrophic, very characteristic. And you can have this information with the en face OCT, and you can confirm also the surface of atrophy, just below the choriocapillaries. And you have also the thickness. With one cube, you have several modalities analysis. Okay? Another case, this is a case of young patient of the cone dystrophy. And look here, this is the retinal thickness and the appearance of this lesion with the en face OCT. In this cone dystrophy, there is some abnormal reflectivity within the outer nuclear layer and also in the external membrane. And look here, this is a characteristic shape as compared with the autofluorescence and the PET scan analysis. You can make a screening of the nevus with OCT angiography, retinal fundus camera to make a correlation if there is an elevation or not, present the fluid, drusen, and pigment. And this is a large scan with a full range retina, with a cross-line acquisition, and you confirm the lesion is completely plain. It's very difficult to analyze this lesion in ultrasound. Another case of hemangioma. With a large scan, you can have a better analysis of the depth of the lesion. And look here, the hemangioma is a very large hemangioma. You can observe that the changes within the retina and the epithelium pigmented. Now, with the Solix Optovue, is the first time you have the possibility to have a same report about the structural analysis with RNFL and GCC, and functional analysis with OCT angiography. OCT, the role of OCT angiography is not very well determined currently, because we don't have this correlation on the same report. We know with OCT angiography in glaucoma, you have several pathways to analyze glaucoma with radial peripapillary capillaries, okay, with a cube of 4.9. The macular superficial plexus within the ganglion cell layer, and the deep complex within the INL with the projection artifact. And we know the nucleus of Müller cell is in the INL. That's why sometimes in some optical neuropathy and other conditions, you have some changes in INL as the cystic degeneration. Okay? With the en-face OCT, you can highlight the defect of the RNFL, and you can compare the defect with en-face OCT with your GCC. And look here, this defect as compared to the GCC, and look here, there is a very slight defect, and you have a very good corresponding aspect in GCC topography. And this is a normal aspect of the fiber layer. In OCT angiography, we already published a good correlation between structural and OCT angiography with vascular macular density, the retinal peripapillary capillaries, and the visual field. But currently, we don't know what is the eggs or the chicken. We know that RNFL analysis show limit of the assessment of the progression in advanced glaucoma. It's very low because in RNFL, the measure is 60% of non-neuronal tissue. That's why we call the floor effect is a very advanced stage glaucoma. In OCT angiography, this floor effect is less pronounced. And we can consider probably the utility of OCT angiography in the advanced stage glaucoma, as is already published by Gabor Olo, in case of very advanced stage glaucoma, also with a retinal thickness. Okay? Because when you have a very big damage in GCC and RNFL, it's very difficult to compare this patient. Okay? But if you use total retinal thickness and OCT angiography, it could be a good approach. And it's the first time we have a structural and functional information on the same report. And look here, this is a glaucoma patient. We observe the thinning of the GCC here with the most pronounced defect on the left side. And you can have also the vessel density in the same report. It's the first time in OCT market you can have the both information on the same report. Another case of line optic neuritis, and look here with the en-face OCT. You can see the defect, and you can follow the patient with the trend analysis of RNFL and OCT angiography. The case of tobacco optic neuropathy, and look here with defect, peripheral defect of GCC, you can make a very nice correlation with the visual field with the central scotorum. And now we're going to talk about the ability of the Solix for the anterior segment. As for the retina, you have also the possibility to increase the depth of the acquisition for the anterior segment using the mirror image and to have a complete image of anterior segment with a large kind of 18 millimeters and the depth with 6 millimeters, high resolution this kind of 10 millimeters, the possibility to have epithelial mapping of 10 millimeters and a 3D cornea en face high resolution. This image enables the possibility to have a very easy and quick biometry. And now with the upcoming software, you can have an automatic biometry with a measure of angle to angle, anterior chamber depth, anterior crystalline lens rise, and the distance of white to white. You can also analyze the white to white directly on the infrared camera with a ring circle measure, and it is very useful for the ICL. And this is the last upcoming software with a totally automatic biometry with anterior chamber B-scan analysis. And you can use all this information with a regression formula as a Nakamura formula to help the diameter choice of ICL. And you can use the anterior chamber depth, the distance to scleral spurs or angle to angle. And you have a table to help this choice. I use this formula on Excel. And look here, this is a help showing of the ICL diameters. And you can also have a prediction of the voting, and this formula gives best results as compared to the star nomogram. And look here, we can analyze before and after phakic IOL, and here the ICL in hyperopic patient, and you can analyze the voting in different light conditions. Scotopic, photopic, and scotopic condition. And look here, in case of ICL, and other case of artisan. You can have the possibility to visualize the whole crystalline lens rise, the anterior capsule up to the posterior capsule to determine the architecture of the opacity. And it can be very useful before the surgery. As in this case of the congenital cataract, you observe a contraction of the posterior capsule, and probably we can have some complications with this kind of cataract. You can analyze the PCO, the whitening and the glistening, and look here, the increase of the reflectivity within the IOL, and look here with the zoom with the same patient. You can visualize the anterior gyrate, and it can be useful also before the multifocal IOL screening. Sometimes you have some vitreous condensation just behind the crystalline posterior capsule, and this opacity can produce diffraction of the light and some disturbance after the surgery. You can analyze the involvement of the crystalline lens rise of mechanism of angular closure glaucoma. Okay, and look here, you can identify the scleral spurs and the Schlem's canal also, and other condition. And look here, gonius initial, concave iris in pigmentary dispersion, angular closure, and open glaucoma. You can control the iridotomy, in this case non-transfixing, in this case transfixing, and you can control with just 3D cube in few seconds. You make the 3D cornea analysis, and you can check the iridotomy. And look here, with this scan, in 4 seconds, you can analyze the location of iridotomy. Okay? You can analyze also some conjunctival lesion, as this case of Nevis, also with the retinal fundus camera also. We can use the high resolution corneal pattern to analyze the different layers of the cornea. And now, with the very high resolution of the Solix, you can highlight the epithelium layer in order to generate epithelium mapping of 10 millimeters. And look here, the first time we had a 6 millimeters epithelium mapping, but many changes occurs in the area of 7 to 9 millimeters. And look here with the 9 millimeters and now with the 10 millimeters. And with a very good scale, with a normalized approach, you can highlight the small changes of epithelium. Normalized approach change the scale to 5 to 2 millimeters scale to highlight the very small changes of the epithelium. And on the past, I proposed classification of the dry eye with the epithelium mapping. In a normal condition, the epithelium is relatively uniform. Okay? In the first stage of the dry eye, we observe an hyperplasia suggesting a mechanism, an autoregulation mechanism between the epithelium and the tears. In a moderate dry eye, we observe the thinning of the epithelium due to the lack of tear, increase the blinking frequency, increase the friction between the eyelid and the epithelium. Okay? In the last stage, we observe the whole thinning of epithelium, probably due to excessive friction and also apoptosis process. We already published a paper of a British journal, and we make a very good correlation between the epithelium mapping and the breakup time. We also confirm in a more advanced stage of the dry eye, we observe the thinning of epithelium. Okay? In a mouse model, we also confirm the presence of hyperplasia after 7 days of dry eye model. And look here, this is the cornea of the mouse. After 7 days, we observe an epithelium hyperplasia. The most likely hypothesis is the increase of pro-inflammatory cytokine induce a cellular proliferation. And look here, in the stage of the dry eye, beginning stage of dry eye, this is a comparison with Nibut. In this hyperplasia is always in the same location of the first rupture of the lacrimal tears. We observe a very good correlation and stability of the acquisition. This is the same acquisition at different time, okay? We confirm with the en-face OCT and the slab, there is an hyperplasia. And look here, we confirm this hyperplasia associated with dysfunction, the mammalian gland dysfunction, and we already control with the slab and the measure of the slab, okay? And look here, the correlation in case of a very advanced stage of mammalian gland dysfunction. We observe an increase of tear meniscus, a short breakup time associated with hyperplasia. And when you give the treatment of this patient with a warm compress and an eye drop, we observe normalization of the epithelium and the increase of the breakup time. And now we are also embedded on the OCT the possibility to have a mammalian gland imaging, and there's a possibility to measure the tear meniscus quantification associated with epithelial mapping. And look here, this is different cases of mammalian gland dysfunction and dilation of the gland. And we can also use the color camera to identify the inflammation of the patient. And look, we can make a screening of the dry eye. This is a patient, a small patient, boys of 11 years old, with an allergic condition. And look here, there is a small MGD with a dilation of the mammalian gland, and you observe an hyperplasia in this inferior part. This hyperplasia presents a good correlation with the stage of mammalian gland dysfunction. And look here with the en-face OCT, you can observe a stagnant member in case of incomplete blinking. You can use OCT en-face to analyze the lipid component. And look here with the Solix, we use a very short slab of 10 microns. And look here, you can observe the lipid component within the lacrimal tear. And look here, different cases of lipid instability. So it takes sense that OCT may play an important role in multimodal dry eye screening with total pachymetry, epithelial mapping, tear meniscus analysis, and mammalian gland imaging. And look, in this case, you observe in en-face OCT an instability of the lipid layer associated with the thinning of the epithelium. And look here, the stability is more pronounced and associated with a more pronounced thinning of epithelium. And you have a multimodal approach also with the anterior segment. And look here, this is a breakup time with keratitis, OCT en face, and epithelial mapping. And you can follow the patient before and after the treatment. And look here, you observe an improvement of the epithelium after the treatment. Another case, before and after EPL. And look here, after the EPL, you observe an improvement of the epithelium thickness. Another case, before and after EPL. And we observe in infrared camera the improvement and the reduction of the telangiectasia after the IPL. In more advanced dry eye stage, also, you can observe the improvement of the epithelium mapping before and after. And look here, you can analyze also the forms of conjunctivocalasis and the improvement of the conjunctivocalasis after the treatment. And you observe here the formation of the tear meniscus after the treatment. You can also analyze the dynamic of the presence of the conjunctivocalasis in the tear meniscus area. In OCT en face, you can have a quantification of this fold with a 3D cornea pattern. We know the number of this fold is correlated of the degree of gravity of the dry eye. And in other cases, patient with a history of LASIK and PKR, we know after the refractive surgery, we observe an hyperplasia proportional to the treatment. But look here, there is a small scleral show. And this is a before, and this is after the treatment. And it still remains a question. What is the role of ocular surface in refractive regression after this procedure? And we can also imagine the future to analyze the eye drop persistent analysis with epithelial mapping and en-face analysis. And look here, when you put an eye drop, you induce a thickening of epithelium, and you can quantify the time back return to the normal aspect. And probably in the near future, we use the OCT to analyze this eye drop persistence. So in refractive surgery, you can also analyze the flap diameter before the retreatment. It can be useful. You can analyze the thickness of the flap and the residual stromal bed, but you can also analyze sometimes some complication. And look here with the en-face OCT, you can observe the shape, the cutting shape of the LASIK, okay? And you can observe also the corneal nerve. And look here with the en-face OCT, you can observe the regular cutting shape of the LASIK with the en-face OCT within the cornea. And look here, some complications about folds within the flap, inducing light diffraction, called the Bagolini effect. And look here, the fold within the flap. Another case of smile. This is a regular shape. You can see here the incision and the intra-stromal cut. And look here, the irregular shape due to the problem of docking. And look here, it still remains a piece of lenticle. And look, the correlation with epithelial mapping. Epithelial mapping highlight every small changes within the cornea, also within the curvature changes. Another case of the complication in the smile with the epithelium ingrowth. And look here, the epithelial cell within the cutting shape. And look here with the en-face OCT, you have a very nice resolution of the cutting shape. And look here, the correlation with epimapping and the epithelium thickness in area of epithelial ingrowth. Another case of the complication in LASIK. Look here, this is the first cutting. The second cutting, the folds within the flap. This is epithelial ingrowth. And look here, this is the entry of the epithelial ingrowth, and this is a B-scan corresponding. And you can make a multimodal analysis in refractive surgery with a B-scan, a fast CT, epithelium mapping, and a stromal mapping. And look here, very nice resolution in case of A's in PRK. And you can also analyze some regression. This is a patient with a historic of PRK for treatment of -8. And look here, there is a very slight epithelium hyperplasia, but it's normal. But look here, you can observe the crystalline lens changes due to myopic index. Epithelium mapping can be also useful to make keratoconus screening. Dan Ranchen was the first to publish the interest of epithelium mapping with R-scan ultrasound. In keratoconus, we observe a thinning of epithelium above the cone associated with the hyperplasia donuts. And look here, this is a case of the patient with thinning of the epithelium and donus hyperplasia, more pronounced on the left eyes. You have also to compare epithelium mapping always with the stromal mapping. It's mandatory because we have to confirm there is stromal changes. And look here, we observe the thinning of stroma and the decentration of the stromal mapping in accordance to the epithelium changes. We confirm that the keratoconus is more pronounced on the left side. And this is a new display of the upcoming software when you can compare total pachymetry with epithelium pachymetry and the stromal pachymetry. Why is mandatory? Because sometimes we have ocular surface disorder. It's very frequent in keratoconus patient, and sometimes you can observe hyperplasia reaction due to dry eye. And look in this case, we observe a thinning above the cone with donors of hyperplasia, but in the left eye, you can also observe a fluid keratoconus, but look the shape of the epithelium. There is a complete hyperplasia due to the dry eye. And you have to compare with the stromal mapping. And look the stromal mapping, you observe a decentrate appearance of the stromal mapping and the thinning of the stroma. And when you have hyperplasia, you have to confirm if there is stromal changes or not, to know if this hyperplasia is correlated to the ocular surface or other changes as keratoconus patient. And look here, the interest of to combine epithelium mapping and corneal topography. This is a case of a young patient with a history of grass allergy. And look here, there is an asymmetry of the corneal topography. And look, in epithelium mapping, you observe hyperplasia associated with the meibomian gland dysfunction. In this level of hyperplasia, it's correlated of the stage of hyperplasia, more pronounced on the right eye. And this hyperplasia induces curvature changes. That's why it's mandatory to analyze corneal topography with epithelium mapping. That's why now, with the upcoming software, Optovue and Visionix develop a corneal topography embedded in the Solix platform, and we can analyze corneal topography in the 10 mm area with epithelium mapping and the stromal mapping. We observe a very good correlation with other competitors of the topography, as CSO with the Schlenflug camera, with the best appreciation of the posterior curvature, the the precision is pretty good. And now we can make comparison with epithelium mapping. This is a case of keratoconus, okay? And this is the shape appearance of the epithelium mapping. You can compare with the stromal mapping, okay? And now we can have both analysis with tangential approach, epithelium mapping. We observe the thinning above the cone, and the elevation, anterior elevation and posterior elevation with a good appearance of the topography, and the other eyes, okay, with a good correlation with the epithelium mapping. And look, in this case of hyperplasia, we can analyze and confirm some asymmetry due to the hyperplasia changes. In other cases, you observe asymmetry of the corneal curvature associated with Meibomian gland dysfunction and hyperplasia. And look here, the shape of hyperplasia overlay on corneal topography. And we have to compare with stromal mapping. Stromal mapping is normal. That's why it's very mandatory to compare corneal topography and epithelial mapping. And look, we can also observe hyperplasia, epithelial hyperplasia in curvature changes. And look, in this case of intracorneal ring, we observe in en face OCT the ring and the hyperplasia above the ring, and also in the small incision. And with the Solix, you can analyze the location of the intracorneal ring. And look here, we can analyze with the whole surface, but not just with the 1B scan. With the contact lens fitting in keratoconus, you can analyze the vaulting of the lens. Okay, here there is a contact. And sometimes some corneal disease like adenovirus keratoconjunctivitis follow-up, you can also analyze the small opacities in the anterior stroma. And look here, when you introduce cyclosporine treatment, you observe an improvement of the ocular surface and the reduction of the small lesion, guiding the treatment. With en face OCT with epithelial mapping, you can guide the treatment in this lesion. And this is trend analysis with the last upcoming software, and you observe the improvement of the epithelium shape and the trend analysis of the whole epithelium thickness. In Cogan dystrophy, you can observe the fold of the basal membrane of the epithelium, and look here with the en face OCT moving through to the cornea. Another case of Cogan dystrophy, look here, with the geographic appearance. In the guttata, corneal guttata, we observe in B scan some very focal reflectivity, and with OCT en face, we observe some very dark aspect due to the dysmetic changes as compared to the specular microscopy. And we can analyze both en face OCT, in this case of scare, in herpetic lesion, and with B scan, another case of cornea verticillata. This is an epithelium lesion, and look here the appearance with the en face OCT. In this pseudo double layer of the Bowman membrane in this typical case. You can also analyze the graft and the endothelial graft. Also, sorry, the video doesn't work. So, in conclusion, Solix is a complete platform for the anterior and the posterior part of the eyes for the retina, glaucoma, cornea, dry eye screening, and refractive. And thank you for your attention.
Thank you. Okay. Hello, good morning to everybody. It's a pleasure to be here in this session sponsored by Visionix, talking about the diagnostic performance of Visionix VX120 Plus platform for dry eye screening. I'm going to show you our experience and our studies with this very helpful platform for our clinical practice and even training with the students. These are my disclosures. First of all, I would like to make an introduction to the VX120 Plus with the dry eye module. This platform is the result of the combination of several technologies. Harman aberrometry, providing ocular aberrometry, the simulation of the point sprint function, and the simulation of the retinal image. The use of Placido-D-space corneal topography, allowing to obtain different topographic maps of the anterior surface, geometric parameters as sphericity, and the aberrometric analysis of the anterior corneal surface. In addition, we have a simple camera allowing to make a pachymetric analysis. We have also an entonometer, a pupillometer, and the dry eye module, which is the objective of this presentation. Regarding the topography and aberrometry of the anterior surface, we can say that this Placido-D-space system contains 24 rings projected onto the corneal surface, allowing to measure more than 100,000 points in an area from 0.33 to 10 millimeters. And it's very important to say that this module has been scientifically validated. We have performed several studies to investigate the precision and reliability of this technology, finding very significant, very good coefficients of repeatability of the measurements of different topographic parameters, and also in terms of anterior corneal aberrations, with a level of within session standard deviations very low, and confirming the usefulness of this tool for the practice. Regarding ocular aberrometry, it provides in 0.2 seconds measurement of the spherocylindrical refraction and high order aberrations with the measurement of 1,500 points, all in 0.2 seconds in an area from 2 to 7 millimeters in diameter, allowing to cover the normal range of refraction of the eye. It's important to say that these measurements have been also validated. This is one study conducted by our research group showing also a very good level of intra-session repeatability with, for example, for the sphere, the level of error between repeated measures is only 0.05 diopters, which is completely acceptable and very, very good. And in terms of high order aberrations, we provided this analysis with, you can see here, level of intersession repeatability below 0.05 microns. And you can see here that for a pupil size of 5 millimeters, these are the range of normality or how the measurements can range in the normal population. Also, with the collaboration with the Hadassah College from Israel, we made this comparative analysis between subjective refraction and the refraction provided by this instrument. As you can see, measurements in most of cases were not statistically significant, showing that the level of interchangeability was very strong, only with a trend to higher level of variability for the higher levels of spherical refraction in negative, it's normal. And you can see here the differences in terms of sphere and in terms of spherical equivalent, showing that in most of cases are within plus minus 0.5 diopters, which is completely acceptable. Okay. Regarding the same-flow camera, it uses 455 nanometers wavelength blue monochromatic light, allowing pachymetric measurements with a resolution of 1 micron in a measurement range from 150 to 1,300 microns. Also allows measurements of the iridocorneal angle with a resolution of 1 degree. This has been also evaluated and investigated in another study conducted by our research group, showing a level of repeatability, especially for pachymetric measurements, which is extremely good. It's comparable and even better to those provided by other instruments that are available in the market. Even we make a comparative study with the Sirius system, with another same-flow camera-based topography system, showing that the measurements of central corneal thickness and keratometry were interchangeable with those provided by this instrument. Regarding pupillometry, we have also the possibility of measuring the pupil size in all these conditions in a very short time. Scotopic condition, low mesopic conditions, mesopic and photopic, and allowing to make a dynamic analysis of the pupillary changes. Okay, this measurements of pupil size has been also validated in another study. This was published in 2020, in which we confirmed that the repeatability of pachymetric measurements were completely acceptable and very good in comparison with other instruments. What happens with the dry eye module, which is the objective of this talk? It's a very interesting module providing a measurement of the non-invasive breakup time, an analysis with photographs, very good photographs of the conjunctiva, cornea, and eyelid margins. It allows an analysis and measurements of the tear film meniscus, and with the use of a modified version of the Efron scale, you can grade different ocular signs that can be present in dry eye. And as happened with the previous modules of this instrument, it is also scientifically validated, as I will show you afterwards. This is the measurement provided of the non-invasive breakup time. It provides you the video of the capture of all the recording procedure, a color map showing how is the distribution of the breakup time, and a graph of the breaks that are happening over the corneal surface during the measurement procedure. It's interesting because it provides two measurements. The first nibud, which is the time point when the first distortion of the rays projected on the cornea occurs due to a tear film breakup. This is interesting, and sometimes we can say it's comparable to the classic version of the measurement of breakup time in which we use fluorescence for making the measurement, but in an invasive way. Regarding the nibud, 50% is the time when half of the subareas of projection presenting distortion was present. And these parameters, I will show you afterwards, is especially interesting. I can tell you that there is a certain correlation between breakup areas and corneal zones with staining, because these areas are areas of dissipation, and you can check sometimes. And when you detect that there is an area in which the nibud is broken very, very, very easily, when you go to the slit lamp and you can find in these areas, probably you will detect some level of corneal staining. This is our experience that we have published with this instrument in terms of analysis of reliability. This study was conducted by our research group, and we confirmed that the level of repeatability of nibud measurements for right and left eyes of a sample of patients was completely acceptable. You can see here, and even we defined a potential range of normality that I will show you afterward, that has been refined with a more complicated analysis that we have performed afterwards. This could be considered as levels or numbers that should be considered when you make a screening with the device. And it would below 5 seconds is abnormal, and an input 50% below 6.5 seconds could be considered as a suspect that something is happening in the ocular surface. This is the study of interchangeability of the measurements, and we can see that the interchangeability are very high, especially for the second and the third, when you make a repeated measurement between, especially the second and the third measurement. Regarding the third field meniscus, as you know, is another parameter which is very useful in clinical practice in the area of dry eye, because it's an indirect measurement of the tear film volume, because you have to consider that among 75–90% of the tear film volume is located on the inferior meniscus, and is extremely reduced in patients with dry eye, and even has been shown that it's correlated with the breakup time. In our repeatability study, we've confirmed that the measurements of tear meniscus are quite repeatable, with a range of normality over 0.20 millimeters that can be considered that's a suspect of a problem of tear film production. Besides the measurement of the breakup time and the tear film meniscus, we have the use of an adaptation of the F1 scale to evaluate different ocular signs that can be present and that are related to the presence of dry eye, as such conjunctival redness, limbal redness, blepharitis, and meibomian gland dysfunction. It should be said that this scale was initially developed for grading the complications associated to contact lens wear, but afterwards it has been used and adapted to the grading of different complications and problems of the ocular surface. But it's important to say, if this scale was initially developed for contact lens practice, it can be used in contact lens practice. It's specifically useful because it seems that the dry eye module is only for patients with dry eye. No, it's a very, very good device to be used to follow how is the contact lens prescription and how the contact lens wear is going on. Okay. This is the different levels of grades of the modified scale of Efron that is used by this instrument. We have normal, trace, mild, moderate, and severe for these 4 aspects: conjunctival redness, limbal redness, blepharitis, and meibomian gland dysfunction. For example, in this patient, it's a very good patient. In this, we can see that the level of conjunctival redness is absent, and the level of limbal redness also is absent, because there is no problem in this patient. I will show other cases with problems, but this is a very good case. And once you have finished all these measurements, you have what for me is very, very, very useful is the screen with all the information in an integrated way. You can see here for right and left eye, the breakup time, first breakup time and average breakup time, the tear meniscus measurement, and the scale of the ocular signs, even with colors, to show you that when you have a one color is something where is a warning, there is a problem or potential problem. Okay, perfect. I want to show you now. I think the platform is now very clear, but I want to show you that this selection of tests in this dry eye module is performed in a very comprehensive way. It's not a question of, I have included this test because, okay, they are very attractive. No, everything is done in a rational, according what is needed for a good dry eye diagnosis. All of you know that how is the definition of dry eye, there was a classic definition of dry eye that has been substituted for a more complete definition of dry eye according to the DIUS-2, stating that, and this is very important, that the dry eye is a multifactorial disease of the ocular surface, and the most important thing is that it's characterized by a loss of homeostasis of the tear film, accompanied by ocular symptoms, in which the instability of the tear film and the hyperosmolarity of the ocular surface, the inflammation and damage of the ocular surface are present, but also neurosensory abnormalities are going to play some etiological roles. It's important to have in mind that we have the activation of two central mechanisms. Hyperosmolarity, we are not going to measure osmolarity, but we can measure the consequences of this hyperosmolarity. When you can find hyperosmolarity, when you have an aqueous hyposecretion or an excessive evaporation of the tear film. This condition causes inflammation and damage to the ocular surface, ocular redness, other problems in the ocular surface, the release of inflammatory mediators such as cytokines or MMPs, the death of the surface epithelial cells and the generation of the corneal staining, causes symptoms, and initiates the presence of compensatory mechanisms of dry eye. But there is also another mechanism which is completely related to the hyperosmolarity, which is the presence of instability of tear film. It's very funny because this condition is secondary to hyperosmolarity, but also contributes to hyperosmolarity, and therefore is a vicious cycle. And we have to break with a treatment this vicious cycle to avoid the progression of the disease. We can say two main types of dry eye, although in most of cases the condition is mixed, combining both components. But we have the hyposecretory dry eye, in which there is a deficiency of the aqueous tear. In this condion, the symptoms is the presence of irritation, foreign body sensation, itchy eye, that is worse at the end of the day, and especially worse in situations of greater tear evaporation. How to can detect this condition? With a decreased aqueous tear production, with the classical Schirmer test or other ones, a decreased tear meniscus, we can measure it with the VX120, and the presence of damage over the corneal surface. Normally, it's measured with stainings, conjunctival or corneal stainings, but this is invasive. And with VX technology, we're avoiding to be invasive. We can analyze the pictures obtained of the ocular surface, but without introducing any substance on the eye. Regarding the evaporative dry eye, in which we have an excessive tear evaporation, we have also irritation, foreign body sensation, itchy eye with the same sensation during all the days. It's different or even worse in the mornings, not at the end of the day. It's also worse in situations of greater tear film evaporation, and here we can find the decrease of the breakup time that we can measure. We can also detect the signs of meibomian gland dysfunction and damage over the ocular surface, okay, which is the representation of the ocular surface disease. Therefore, for the detection of dry eye, this is the combination of tests that we have to do. Please think about it. Do you think we can afford to make all these tests to all patients entering into our consultation? It's impossible. But we can make an efficient screening of some of these aspects, telling us, David, you need to make more tests or not, or it's enough, and this patient has no problem. Regarding the evaluation of the tear film with the VX, we can evaluate the quality because of the tear film, because we measure the breakup time, but also we can measure the quantity with the meniscus scale. But also we measure the tear, what is the damage over the ocular surface, because we can use grading scales of the ocular redness. Okay, with this combination, we can have an idea of what's happening on the ocular surface, and even we can have an idea there is more component of evaporation or hyposaturation, okay? Because the evaluation of the tier of hyperosmolarity is a very complex evaluation and expensive. And the symptomatology with a validated questionnaire as OSCE, I recommend to do it always. This is a very easy task, and you don't need any instrument. You only need to fill the corresponding question. Okay. Regarding the non-invasive breakup time that we have shown before that we can measure with the VX, it's important to say that in this case fluorescein is not used, and we can measure the tear film stability according to the alterations that are occurring in the miles projected onto the cornea. Some authors have reported that Nibud values are lower than those measured with fluorescein, but others say the opposite. I think it's very difficult to know. But what is true is in dry eye, normally, Nibud is somewhat higher than the good measured with fluorescein. Therefore, we cannot extrapolate the cutoff points defined in the literature for fluorescein with those that we have to define with this instrument. There are, with other instruments, different types of Nibud cutoff points that have been defined, around 8 seconds in this case, or 5.9 for another instrument. For example, here you have with different instruments 2.65, another one 6.2, another one 6.3. It's very variable because it depends very, very significantly on the how this rupture of the miles is performed. It's true, and you have to consider that although the use of the Nibud can be very sensitive to detect dry eye, it's not very specific because you need more tests, but it's good for making a screening. Regarding the tear meniscus, something similar. There are a lot of literature on that, but here we can say it's more consistent because most of the studies shows a value around 0.20, 0.22 has the limit in which a patient can present a dry eye or not, even somewhat lower in some cases. Therefore, it seems very similar to what we have found in this in our study with this platform, with the VX120. And regarding the Efron scale, we have used, because the Efron scale has a lot of signs that you can evaluate with different pictures and with different grading, normal, trace, mild, moderate, and severe in all cases. And you can, according to the pictures that you can see perfectly the eye of the patient or all the features of the ocular surface, you can make the patient to look at one position to other. You can detect and make a precise, we can say, evaluation of these ocular signs that you can find in these patients. Okay? Perfect. Let's go then to the diagnostic performance. We have proposed several parameters, Nibud to breakup time, tear meniscus, some values that can be approximately useful for the detection of dry eye. But we have performed a more comprehensive study in our clinical practice that I hope is going to be published very soon. At least we have the first positive review of this investigation, and we have tried to define exact cutoff values for the non-invasive breakup time. This was a study developed in the optometry clinic of the University of Alicante. It was approved by the ethics committee of our university, and the inclusion criteria were adults with corrected distance visual acuity of 0.10 logMAR or worse. And we created two groups, the dry eye disease group and the control group. The clinical diagnosis of dry eye disease was performed according to the following criteria: an OSDI, a symptomatology of 13 or more, and at least one eye meeting at least one of the following criteria: a silver one test without anesthesia lower than 10 millimeters at 5 minutes, a tear film breakup time lower than 10 seconds, and grade 1 or higher in the Oxford scale of corneal or conjunctival staining with fluorescence. This is to be sure that we are in front of a real case of dry eye. Exclusion criteria were no history of ocular pathology different for dry eye disease, no history of ocular surgery in the previous month, presence of corneal alterations that could influence the study results, and we try to avoid those patients taking chronic medical treatment with drugs such as anti-inflammatory drugs or antihistaminic drugs or drops or whatever. And our objective was to make this comparison between the classical method of measuring the neighborhood in an invasive way with that performed in the with this new technology provided by VX. Okay, and we make the comparison, but in this case with the certainty that we have patients with dry eye and we have patients, normal patients, because we have performed a very detailed analysis in all cases. Here you have in the superior part, for example, we have a patient that we can have doubts because we have a first neighborhood of 5.1 seconds, but the average neighborhood is 9 seconds, and you can see that the tear meniscus is 0.23 millimeters. We can say we are in the limit. And in this case, there is some level, a trace level of conjunctival redness in the right eye and a level moderate of blepharitis in the left eye. This was a case that, in this case, this patient was considered as normal. They have no symptoms, but you can see that it is in the limit of what we can find. In the lower part, this is a patient that can attend to your consultation, and you can think that is a normal because this patient wants a refraction only, but you can see that the first neighborhood is only 3 seconds. The tear meniscus is clearly good, 0.26 millimeters, 0.31, but this patient has a mild level of conjunctival redness and a trace level of meibomian gland dysfunction. It's clearly an evaporative dry eye. There is a suggestion that can be, but this patient has symptoms. Therefore, what I have only to make a refraction. What do you think? No, it's telling you the instrument. This patient needs a comprehensive analysis. In the other case, which is in the limit, probably you can doubt. Some of you will do a complete analysis to be sure, but other ones says, okay, we can make a checkup in 6 months because it seems that everything is okay, but we have some suspect. Okay, it's up to you. But you can see how helpful can be the device according to that. Regarding the scales, these are cases from our study. The superior case is the patient that I have shown the first breakup time and tear meniscus results. You can see that everything is normal. There is no signs of conjunctival redness and anything. But for example, in the other eye, you can say that there is some level, as I have told you, of meibomian gland dysfunction. It's a mild level and some level even of blepharitis. Therefore, this patient needs a careful analysis and ophthalmological analysis to define a treatment of the blepharitis and the dry eye. Okay, they don't have to, because sometimes I have to tell you that this happens with dry eye patients, as they have a lot of symptoms and they are not seeing very well. They don't know what is the problem, and they think it's a problem is they are not seeing well. When you put a refraction, they are seeing well, but they are still symptomatic, and this is the problem. Okay, let's go to the research. Here, we finally evaluated 58 eyes, 30 right and 28 left eyes, so 58 subjects with this in age of 48.8 years. And we created 2 groups, the dry eye disease group including 34 eyes, or 34 subjects, with this mean age, 52.2 years, and a control group of 24 eyes of 24 subjects with a mean age of 44 years. When we evaluated the baseline conditions, you can see here that there were no differences in terms of refraction, visual acuity, only in the OSD questionnaire is normal, because the group of dry eye has more symptoms. It's normal. Also in NIBUD 50%, but not in the first NIBUD. This is important. And also, logically, in the fluorescein record time, and also in temporal conjunctival staining with more staining in the loop of the dry eye, and as can be, and the rest of things are very clear. You can see here that most of our samples were evaporative dry eyes, or with a clearly evaporative component, because you can see that the Schirmer test production was very good. Okay, and we make a ROC analysis to detect which is the best test for the detection of dry eye. And you can see here that if we use the tear meniscus height, we have a cutoff point of 0.29 millimeters, and the sensitivity and specificity is about 62% and 67%. It's okay, but probably it's not so sensitive and specific, because most of our samples were dry eyes with evaporative component. But you can see the first NIBUD that we have a cutoff point of 5 seconds, as we said before, with 85% of sensitivity, but the specificity is not acceptable. I think the best of all was the use of NIBUD 50%. Here we have a cutoff point of 7.35 seconds with a level of sensitivity 65%. Could be better, but it's okay. And the level of specificity is quite high. The good thing is that we can combine the three parameters, and probably this is what we are doing now in a logistic regression model. It's what we would like to do in the future to obtain a model of prediction still better. But you can see from all these parameters, according to the statistical analysis, I would recommend the use of NIBUD 50%. Regarding the comparison between the NIBUD, the first NIBUD and NIBUD 50 with the conventional measurement of break eye time with the fluorescein, you can see that the mean difference is not very high. 1 second in one case and in other case around 2 seconds, but the problem is the level of interchangeability between tests was very high. You can see that there is a level of potential variation of more than 5 seconds, and this means that it's not acceptable. But you can think about it, that the measurement with fluorescein is completely variable and extremely subjective. Indeed, the first NIBUD was significantly lower than the fluorescein BUD. It detects earlier the first break, because with the viewing through the slit lamp is more difficult to detect the break of the tear film. And regarding the NIBUD 50% is significantly higher than the fluorescein breakup time. It's the opposite. Okay. And in conclusions, it's true that this instrument is, for me, is a very good device to be used in the clinical practice, because it's optimizing the resources, because you are going to detect those cases that can need a more comprehensive analysis. You don't have to make too many tests to all patients, because it's very time consuming, tiring for the patient, and I think this is more appropriate and not so tiring. It's very fast, the procedure of measurements. Concerning the parameters, it's true that the NIBUD 50% exhibits better diagnostic capability for dry eye diagnosis than the first NIBUD and tear meniscus height. The acceptable values of sensitivity and specificity make this parameter a useful tool for dry eye screening even, and it's important to say that the tear film measurements obtained with this device cannot be used as interchangeable with those measured with a slit lamp. We cannot make this. It's better. We can see that the level of variability is lower with this instrument because it's an objective measurement compared to the other one. And important, the cutoff values obtained in the current series cannot be considered as applicable to other systems measuring the same parameters because it's the algorithms of detection of the breaks of the tear film are very different according to the instrument. And I hope you have enjoyed this talk. Thank you very much for your attention. This is my email address. If you need anything or if I can help, I will be pleased of helping any question on any thing that you need of me. Thank you so much.
Thank you.
On time.
On time, right on time. Perfect. Thank you.
Hi, good afternoon. My name is Robert Rothstein, and I'm a neuro-ophthalmologist and glaucoma specialist. And I practice in Queens, New York. And in the practice, we have a multitude of patients with diseases of neuro-ophthalmological diseases and glaucoma diseases. And additionally, we also see comprehensive patients with that need comprehensive eye exams. I wanted to speak today about the Optovue Solix, and it's and why the Optovue Solix. What makes it a unique device, and what makes it differentiates it from anything else, and how it has really impacted my practice of ophthalmology. And I will be discussing case studies and some of my insights into this with using this device. So the question is, why the Solix? Why the Optovue Solix? And essentially, the Optovue Solix is a multimodal device. That's really in a nutshell. It can basically image the entire eye. The OCT is not just an OCT that just images the posterior segment, the retina, and the optic nerve. This can do a whole lot more. It's multifunctional. So we have full range anterior segment capability, the ability to image, evaluate the surface of the cornea, the surface of the lens, the angle, and assess ocular surface disease. We have the ability to evaluate full range retina, which is a much larger scan with higher definition. We also have new scans with new scan patterns that have better reproducibility and repeatability with earlier detection. And the piece de la resistance is exclusive angio analytics. Optovue was actually the first company to have OCTA 3D technology. And it is actually the only device that it was FDA cleared for its metrics. And while outside the United States, other devices do have metrics, it is still the only device that went through the rigorous process of getting through the FDA. And that says a lot in terms of when you actually want to really assess its ability to measure these factors. So what does that mean, multimodal technology? Well, multimodal means the front of the eye. So we have external photography. We have meibomian gland visualization using IR, infrared meibography. And we also have photos that you can take of the cornea, sclera, and conjunctiva that can then correlate with a OCT scan, as you see on this slide. One of the real important features of the Solix is its ability to perform corneal and epithelial thickness mapping. It is able to perform a pachymetry map, is able to perform epithelial thickness map, as well as a stromal thickness map. Now, why is this important? Well, pachymetry, obviously, we all know is important with the diagnosis of glaucoma, as thin cornea is a major risk factor for glaucoma. But it's actually, I find it actually helpful as a cataract surgeon. There have been times where after cataract surgery, uncomplicated cataract surgery, that a patient has had suboptimal vision. And on slit lamp examination, there's no really obvious sign of corneal edema. But when I perform a pachymetry map, I see that there is some subtle edema there, and that can actually explain why the patient is not seeing as well as I think that patient should be seeing. And what's nice about the pachymetry map is you can actually follow it over time, and you can actually see it improve. And in most of my patients, when that is the problem, when the corneal edema resolves on the pachymetry map, so does their decreased visual acuity. It's also useful for any kind of corneal edema that needs to be monitored. Now, epithelial thickness map is really useful in really two cases specifically. It is a excellent tool to screen and diagnose dry eye disease. And once diagnosed, it is a great tool to actually monitor the improvement or progression while on treatment. The epithelial layer gets very thin in dry eye disease, and there are studies that have shown that. And that is actually evident on the epithelial thickness map. This is basically shows two slides. One slide is actually showing the dry eye component. There's another thing that the Solix can do. It can actually measure the size of the tear foam if that's something that someone wants to follow. Now, the epithelial thickness map is actually the best tool to diagnose early keratoconus. It is actually more accurate and will diagnose it more effectively than other technologies such as shine-through imaging. There is a classic pattern that's described by cornea specialists, a donut pattern that one sees, and that has to do with the cone itself and thinning and thickening around that cone, and that's what it sees on the epithelial thickness map. The full range anterior segment imaging is really what makes this device stand out. As you can see, you can see in one scan, you're able to see the entire anterior segment. You can see the sclera, the entire cornea, white to white, and you can see the iris, and you can see the lens itself. With this, you can actually estimate what the angle, the degree of the angle. You can actually find out what the anterior shaper depth is, and if you actually shift the scan to scan more deeply, or shift the depth of the scan, you can actually image the entire lens itself. You can measure lens thickness, and more importantly, you can actually see lens opacifications, which is important for two reasons. Obviously, it's great for documenting visually significant cataracts, but it's really helpful in educating your patients for the need of cataract surgery. Again, I'm reiterating that this is one device that's doing all of this. Again, this is a device that once we thought was only meant for the posterior segment, and now we're really focusing and we're able to see so much in the anterior portion of the eye. But and for those who are refractive surgeons, you can actually look and you can actually evaluate the position of an ICL. Moving to the back of the eye, we have a much larger image of the retina in terms of width and height. We have 16 by 6.25 millimeters, which is really very helpful when wanting to get a much greater length of the retina, and also being able to visualize the vitreous itself. This is especially important in patients who have high myopia. Just to show you what the other devices do, they typically have a 2 to 3 millimeter window. And again, this is the other swept source. I'm sorry. The spatial domain devices. Now the Optovue has OCTA angiography, and it's able to image a 6.4 by 6.4 millimeter to help ensure complete ETRS data, even when fixation is slightly off. It's able to produce a 9 by 9 and a 12 by 9 millimeter, 9 by 9 millimeter and 12 by 12 millimeter image as well. If one wants, using montage abilities, one can go as large as 16 by 16 millimeters. Optovue angiolytics OCTA metrics are the only FDA cleared metrics, as I said before. And one is able to assess flow area measurements, non-flow area measurements, FAZ metrics, retinal vessel density, and disc vessel density, which is also known as radial peripapillary capillary density. And these are just some examples that are provided that show you the foveal avascular zone in normal and diabetic eyes. You have a normal eye, you have a diabetic eye, and you have more advanced diabetic disease. So this is the actual avascular zone, foveal avascular zone. And you can monitor FAZ change over time. This is obviously with the predecessor of the Solix, the Avanti, which also had OCTA. And moving to vessel density, this slide also shows you how vessel density is indicative of the severity of diabetic eye disease, diabetic retinopathy. You can see that as the disease worsens, so does the vessel density. It decreases. And you can actually similarly follow that along over time and see the decrease with as disease increases in severity. Now, let me just speak a little bit about how this data is presented to you. It's presented in a way that your eyes look at it and you pretty much have all the data in one place in different iterations so that one can really assess everything on one page. Now, the Solix does have fundus photo capability, so one could opt to have the photo taken so that one has some reference to the actual fundus photo. And as you can see, as we go down, we actually have the actual B scan of the macula or of the fovea there as well. We have two representations of retinal thickness. One, which is the absolute retinal thickness, and the other, which is the ganglion cell complex thickness. Now, here we have the absolute numbers, but one can actually also, when clicking with the deviation map, you can get ganglion cell thickness. And while here you actually have it's highlighted in terms of what is clinically significant. These are averages, but one can actually get a map as well that shows you the actual thickness in a pixel to pixel normative database map. Below, you see you can actually see the data itself, the numbers, the metrics itself, superficial vessel density, deep vessel density, the foveal avascular zone, and last but not least, retinal thickness, foveal, parafoveal, and in terms and looking for asymmetry. In the middle, we have these en face images that also show angiographic imaging on different layers of the retina, which can also be altered, and one can also see this in 3 dimensions. Now, the optic disc analysis is similar. You have basically 3 views of the optic nerve, giving you 3 different perspectives, pictorially, and then you also have the data in the center. So you have your picture of your optic nerve. You have a pixel map of the normative database right next to it, and below that you have the peripapillary ring, or the optic disc ring, that provides some greater averaging and it's divided into 8. And below that, we have the actual image of the optic nerve capillary bed. And then on the sides, now, just again to point out, just with a little click here, the GCC thickness is the absolute numbers themselves, but with a click of the deviation map, you could actually see a pixel to pixel depiction of loss, ganglion cell complex loss, which is based on the normative database. Now, moving forward downwards, we have further averaging of the RNFL thickness. We have averaging of the superior and inferior hemi portions of the retina, and then also in quartiles. And similarly, we have the same thing done with vessel density. We don't have a normative database with the vessel density, but what we really should be using that for is looking for asymmetry. And of course, when we're doing this in terms of long term, we could also be obviously looking to compare it to previous scans. And finally, we do have a B scan of the OCT. In the middle, we have, again, different analyses. We have the actual graph or tracing of the optic of the RNFL, and then we have the RNFL analysis, looking at the superior and inferior RNFL. We have optic nerve analysis, which looks at the cup to disc, and we have ganglion cell complex analysis, and finally we have the RPC vessel density. Now, I just want to bring up the fact that Visionix and Optovue, the same company, but they really worked very hard on upgrading the technology. So it's not the same device that they had beforehand. It has, this is just technical data, but some might want to know about it. 120,000 A scans a second. It uses deep learning for improved segmentations of the layers of the retina. It uses infrared tracking, which are 30 frames a second, which is quite fast. It also has a motion-corrected technology to correct for microsaccades. It's one of the real beauties of this device is it has what's called projection artifact removal, which was available in the earlier iteration of the device, but which has been upgraded to really remove as much artifact as possible, making the actual evaluation and analysis more accurate. What really makes it stand out is how it performs the scans. The retina cube is 6.4 by 6.4 millimeters, which is a little bit above the ETDRS. But again, that's so that if there's a little bit of shift in fixation, we're still capturing the necessary part of the macula. And because it does that, there's the separation between one scan and another, one B scan and another, is 12.5 microns. The optic nerve is similar. It has a 6 by 6 millimeter cube scan, and the spacing is about 11.7 microns between them. Now one would ask, what, these numbers are really, like, what difference does it make? Well, it makes a difference only that the competitors have or sometimes double in terms of the spacing. So that, again, this device actually has a greater resolution. Additionally, the way that it assesses the cup to disc is different than the previous device because it evaluates the Brooks membrane, and it goes 150 microns above it, and it's able to get a more I would say accurate or more consistent cup to disc that one might find when evaluating the cup to disc themselves. Finally, what's important is its repeatability and reproducibility. That's really very important because that goes to the heart of, can we trust this device when we see change over time? So its repeatability and reproducibility is about 0.7 microns. So if you see any change above that, and it's consistent, it's pretty much something to be concerned about. Other devices are almost twice that much or more than that. So that's really important. So this is a trend analysis, which again gives you the opportunity to follow patients over time, and it looks at both you have the actual images of the optic nerve in terms of being able to look at the thickness and the ganglion cell. And again, clicking it allows you to really modify what you want to see, whether it's that circular grid or whether it's the pixelated normative database. And on the bottom, you can actually see the actual numbers themselves, the averages, and that are being followed. For those who have an Avanti and are thinking of switching to the Solix, it also gives you, there is a feature that allows you to see the actual graph of the trend analysis. So it gives you the ability to somewhat compare apples to apples in that sense. But the data is not transferred. This is new data because the technology is new. Now onwards to the to my case studies, because this is where what they say, the tire hits the road. So this is a patient who presented to me, and I'm just going to tell you a little bit about him, a little blurb. He's 62 years old, and he's telling me he hasn't been able to see right for a little while. And so you can see on the right side, you have this temporal hemifield defect. And on the left side, you have something that sort of is on both sides of it. There's something temporal, there's something on nasal as well. I'm going to show you how I went through evaluating this patient. And here we have the OCT of the RNFL. And we have a pixelated map on the right side, which shows superior and also nasal RNFL loss, which you can also see in the actual peripapillary ring, which is averaged over there. And on the GCC side, we see this very interesting pattern of GCC loss that's only on the nasal portion. On the left side, we have superiorly and inferiorly RNFL loss, and on the ganglion cell, we see a more dense loss nasally, but we also see it extending temporally. So what do we think this is? It's a large cellular and supracellular mass that's displacing the optic nerve and chiasm. And it's displacing it nasally. And it really, really fits what we're seeing on the OCT. There's an amazing correlation to the actual mass itself and what it's doing to the chiasm and the nerves and what we see on the OCT. Now, while this might sound like you see one or two of these a year or maybe never, what's the point? So there is actually an interesting learning and teaching point. If you do see, for instance, classical pattern of GCC loss nasally, binasal GCC loss, you should really stop it, even in the absence of visual field loss, one should think about a paracellular mass. And if one wasn't able to order the imaging, one should refer this patient to either a neurologist or, more importantly, a neuro-ophthalmologist. This is another case of a patient I've been following for years. Before I was following her with the Optovue Avanti. And you can see that they're very large cups. But interestingly enough, really no damage. I mean, here, this is the actual pixelated map. So there is it's picking up some thinning supranasally, but there really isn't any damage or loss either on the RNFL or the ganglion cell complex. And these are the visual fields. And this is a patient that I have followed for umpteen years. Now, this is a patient who does not have glaucoma. This is actually a great patient also to look at with the OCTA, okay? Because the OCTA would be also another tool to look for decreased vessel density at the optic nerve. And that's something one could technically follow over time. The OCTA actually is a very good tool to look for patients who have or glaucoma suspects to look for early disease. If anyone has questions at the end, I'm happy to answer them. Now, this is another interesting case. This is a right heminopsia. It's a 67-year-old patient that came to my office. He has a chronic posterior cerebral artery infarction, okay? And these are his visual fields. I mean, not visual fields, OCT. And what is interesting is that even when one has such posterior disease in terms of in the brain itself, meaning we're talking about the fact that it's really behind, and it's post geniculate ganglion. Even then, we are seeing retrograde, axonal retrograde degeneration. So this is something which is interesting to see, and you might see it in patients who have had strokes. Optic drusen is another useful entity to image with OCT. You can see the autofluorescence. You can see it on B-scan. And this is what the optic nerve drusen looks like on histopathology. You have these vessels on the surface, and you have these deep buried drusen with calcification. Now, I'm just going to show you what the images look like on, on OCT, with the regular B scan. And what I actually like to do is I like to actually invert it and look at it almost like what I would be seeing on a histo slide. And you can actually see, because this is actually the angiography, you can see where the blood vessels are, because the blood vessels are marked by the red. And they're actually, it's eerily very similar to the slide. And then really, the drusen themselves are below that. The drusen are actually right over here and right over here, and they're hypoechoic or echolucent, as opposed to what one sees on a B scan. Now, what's going to be important is how to differentiate patients who have pseudopapilledema, optic nerve drusen, versus papilledema. So the important thing to see here also is the fact that the Bruch's membrane actually, you can see, is angled downwards, and often that's the opposite in true papilledema. So if one sees this pattern, one can be confident that this is a patient that does not have papilledema. Next case is normal tension glaucoma. This is a 65-year-old gentleman that I have been following for several years. And I'm just going to show you different OU reports to give you an idea of what we see. The first OU report is the actual thickness itself with the numbers in the actual circular grid with the pixelated map. But now you have the pixelated map on the GCC thickness, and you also have normative database flagging the portions of the grid, the circular grid, that are abnormal. And here we see what I wanted to show you before, is that this is a patient who I've been following in the past. So in this portion, we have the old OCT, the Avanti, and we have the new OCT, the Solix, over there. This patient actually was progressing, which already was picked up by the Avanti, but seems to have continued to progress. And the intervention I made was to perform an SLT. Moving on to papilledema. Papilledema, we have a patient over here in her 30s who I would say has moderate to severe papilledema. She had grade 4 to 5 discs in the Frisson scale. And here, again, I sometimes like to do this because it gives me, I like to flip the images because it allows me to see certain structures even better. And here you can actually see, that, well, certainly it's not tilting downwards, okay? It's, if anything, it's straightening, and it perhaps might be going up. When it goes up, it's certainly pathopathic mnemonic, but there are other signs as well. But it's something to look out for. And this is the actual thickness map without any normative database to analyze it. And you can actually just see, just by the colors themselves, how the papilledema is improving. This is similarly this is just a ONH GCC trend analysis, which also just shows you, well, first of all, it actually shows you the tracings themselves, and the tracings are really out of the what would be considered normal, and they're supernormal, and you can see that over time they improve. So the intervention in this patient was she had a venous sinus stent performed by an interventional radiologist, and her papilledema resolved. This is an interesting case. This is a woman who was in her 70s, and she presented to me with what I initially thought was an ischemic optic neuropathy. If you look carefully, you can see that there is hemorrhage inferiorly, there's some swelling inferiorly, and my first thought was this was an ischemic optic neuropathy. But then I looked more closely, and what you can actually see here is you can see at the edge of the nasal edge of the optic nerve, you can see this traction pulling on the optic nerve. And this is what's actually causing that swelling. And ultimately, it seems that there is less traction, although you can somewhat still see that area, and the swelling actually did resolve. And this is another representation, but it's more a thickness map representation, the absolute thickness map. And what I'm showing here is another feature. You can check the box that says difference, and then instead of looking and looking back and forth and looking for the absolute numbers themselves, you could just follow the trend and actually see what the difference is. And you can see at the end that the swelling has resolved inferiorly by 104 microns and 234 microns. This was an interesting case that presented to me, and I'm showing you the UBM first. This is a patient who had a sutured IOL and presented with decreased vision and was referred to me for evaluation. And this is the OCT of her optic nerve. You can really see the first OCT is really all over the place, and you can begin to see a pattern that's still very swollen that over time decreases. And this is just to show you that this imaging is showing you the actual difference or differential between the initial study and follow-up studies. This is what the macula looked like. So the macula, there was severe CME. This is just to show you a trend analysis of the retinal cube, which shows you that over time it decreased. And the same trend analysis, but now with the actual normative database. So you can see it's red. It's all red because it's severe, but it over time has improved. So what did I do? I mean, similarly, this is just another way of looking at it. You can see that the RNFL thickness has, and the GCC thickness the macular thickness has improved. What did I do? I put the patient on Prolensa and difluprednate, and over time, which took months, the patient, this resolved, and the patient's vision, came back to basically normal, and we didn't have to do any surgical intervention. Hypotenuse maculopathy is another entity that's very diagnosable with OCT, especially subtle cases. Oh, what happened there? Okay, it's still there. As a glaucoma surgeon, I cause a lot of hypotenuse maculopathy. Patients who have glaucoma surgery have decreased vision, and it's not obvious when looking at the macula. I mean, by the time it's obvious on the macula, their vision is really bad. But even then, it's helpful to have an objective tool to monitor either progression or improvement. And so this is a patient actually who had hypotenuse maculopathy. It resolved. If I'm not mistaken, I did laser suture lysis. The hypotenuse maculopathy returned, and ultimately, because the pressure came back up, it resolved. But it's a really very excellent way to actually monitor this. And here are just different representations. Here is here it is with the actual certain normative database that's averaged. And here is just your raster comparison. Raster imaging is something I've not really spoken about, but it really is an amazing way to really see evaluate the optic nerve and the retina in true high definition. I'm going to talk about a young lady who presented to my office with decreased vision, pain on eye movements. She was in her early 20s, and these are her visual fields. There's a central scotoma. You could see, again, on the actual disc cube multi-scans view that there's swelling. And this map is really helpful because sometimes it could be much more, it could be very subtle. And the only real sign is on the OCT. I neglected to show you what it looked like on the Optos, but on fundus photo, but it was actually more subtle. And you can actually see that it improved with time. Again, with the click, you can see that it improved with time, the swelling, but as the swelling resolved, we now have RNFL loss that's you see on a pixel map and ganglion cell complex loss. Interestingly enough, when the patient presented, she also already had some RNFL loss in the left eye. And disease like multiple sclerosis can often have asymptomatic RNFL loss. And that's actually another tool that OCT is a very useful tool in patients who have multiple sclerosis, even if they've never had an episode of optic neuritis. This is just showing you, again, another way to look at the data with that peripapillary ring. I think I'm up to my last case, really. This is an unfortunate case. A 14-year-old boy who has a sister who's a few years older, who's already blind, and presented with very mild swelling, okay? I'm just showing you really the grid to show this is actually a raster that just shows you mild swelling on both sides. And here you could actually see that as well. You can see swelling that improves. And here you can actually see that at the very end, it's all blue, the macula. And that's because this patient has severe ganglion cell loss. And this patient, when we did testing, had one of the genetic mutations for Leber's hereditary optic neuropathy. So in sum, I think the Solix is a device that can really help diagnose all forms, all types of ophthalmologic disease, and I find it incredibly useful. I'm open to questions.
Yes, no question. So thank you so much for your presentation, and a lot of interesting cases that we don't get to see. We get to see a lot of mundane, I guess. Thank you.
Thank you.
Thank you very much.
Brazil. Excuse me, your name?
My name is Bob from Belgium. I'm working for a distributor.
Okay, good. For distribution as well? Okay, good. I've already done some activities to distributors. So it's good for me because I do already have some experience regarding positioning for distributors, the Visionix VX120. So I'm going to stay right here beside the main monitor so we can talk about it. Okay, good. The thing is that I think Visionix is an outstanding machine for a large number of cataract surgeons. It's very, very important now. For instance, in terms of the same competitors in this arena, cataract surgeons and equipments, we have aberrometers like OPD from Nidec, OPD scan, the iTrace from Tracy Technologies, and, well, the Visionix. So, how can this equipment help the workflow of cataract surgeons? Now it's the prime time, just a moment. Now it's just the prime time for aberrometry in cataract planning. So it's an opportunity. If you do have colleagues regarding cataract surgeons, you must present this technology to them, because if they learn how to use it, it will be an invaluable tool for cataract. Cataract is the most performed surgery in the world compared to any other surgery. So there's a place for this equipment. And not only that, it's very important. Aberrometry is very important nowadays for what we call premium IOLs, premium intraocular lenses, because it gives information about the pre-op analysis and also the post-op performance. Currently, the most important IOL in the market are the enhanced IOLs. These enhanced IOLs give, better near or intermediate vision, but at the cost of giving some aberrations to the lens, to the intraocular lens. So this better performance for intermediate and near vision is under aberrations. And Visionix is very well placed in terms of using aberrometry in order to understand if the lens is performing well or not. So, aberrometry is the name of the game nowadays. Aberrometry is in the market for about 15 years, but now because of these IOLs, it will come the golden age of aberrometry. So, cataract surgery, as I mentioned, is the most performant surgery in the world. So, there's no doubt that the equipment, Visionix VX series, or any aberrometer has an important place in cataract surgery. Well, when we think of cataract, we think of the performance of the visual system. And when we think of the visual system, it's quite different from an optical system. An optical system would be compared to a camera, for example. It has just a system of lens and capturing the image. But our eye is connected to the visual system, which is the cortex, which is the brain processing, which is the software, I would say. So it's very important for us to understand the whole visual system in order to, whenever we assess a cataract, we plan in terms of how can we analyze the current status of the eye before the surgery, and then after the surgery in terms of the options of intraocular lens that you have. Well, actually, in terms of the cataract, we know that it's an optical system. So we have the cornea, which is a very high powered lens as well. The cornea has about 40 something diopters. My glasses have 1 diopter. Cornea has 43 diopters. It's awesome. Positive 43 diopters. Well, the inner lens, the lens has 20 something diopters. So the whole eye has about 60 diopters. 60. It's a very powerful optical system in order to point a single focus on the retina. So the game is, we have to assess how the most external lens behaves in terms of aberrations, the cornea itself. So then we have to assess the lens, the internal lens, which develops into cataract, in order to replace the cataract and give, I would say, a better vision than this patient was when he was young. So I should change this natural lens either in cataract or even in transparent lens, because sometimes one option is not to delay the surgery. You just replace the lens, the internal lens, with an intraocular lens to give, for example, multifocality, so this patient does not have to use glasses anymore, or addressing the astigmatism. So this patient depends less on his glasses. When we assess the cataract, one thing is that we have to understand that there's a difference between the optical system when you're young and then when you're older. For example, when you're young, the internal lens is quite good. It forms a very nice focus on the macula. But when you get older, this example shows a 72-year-old eye. The focus is not that good anymore. But the thing is that the cornea hasn't changed so much during all this time, but rather the internal lens has changed because of cataract, because of changes of shape, etc. So it's a bad quality internal lens. So that's why the focus is not that good anymore. You're thinking you have bad vision and you think on performing the surgery. This imperfection in the internal lens due to cataract and also the aging of the lens induces several disturbances in the vision. For example, the halos and glare that you have when you see the lights. So this is the vision that one would have in, for example, with 60 years old, a cataract. He has poor vision. He would need glasses to enhance his vision, but with not great quality. And whenever you perform a surgery, you implant, for example, a nice trifocal intraocular lens, then you regain your vision in terms of distance, near, intermediate vision, but also you have more contrast sensitivity in your image. So this is the main objective of the cataract surgery, but you see, it's quite different with the technologies we have nowadays with the current intraocular lenses. It's quite difficult for you to have the same vision you had during your younger years because the current IOLs, the current intraocular lenses, they do split light energy in order to form near and intermediate and distance vision in order to form three foci. On the other hand, when you're young, because of your internal lens changes its power, you have all the distances, but without splitting the light energy. That's why in a younger eye, you have better quality of vision. Well, the surgery itself is quite straightforward. You have to remove the cataract and then you have to replace it for an IOL. But where does the aberrometry enter into this game? Whenever you remove the internal lens, either due to cataract or either due to aging, you will be left with the cornea and a new lens, a new artificial lens. And it's very, very important that this new lens couples with the cornea. So any information regarding the cornea is vital for my analysis, for my planning. Visionix gives the full amount of information for me in terms of, for example, the cornea performance before the surgery. This is a very, very interesting example of one of my patients. After the surgery, I performed the surgery of this patient because of cataract, and I implanted a trifocal IOL. And after the surgery, he brought me this drawing. He mentioned that he saw the headlights of the cars like this, with halos and like stream. And he drew this image for me to illustrate how he saw the lights. And now I don't have to rely only on his information or on his goodwill, because he drew what he was feeling. I have now instruments. I don't have to fly blind anymore. I have, for example, the Visionix, which has a Placido topographer, which has a Hartmann check aberrometer with high density of analyzer. So I can assess either in pre-op or post-op the eye health. It gives me the IOP. It helps me to assess his eye fundus with a retinography. It helps me to assess the cornea and surface. What do I mean by surface? Because it allows me to assess the tear film as well. So, Placido topography, corneal aberrometry, and tear film analysis. Tear film is very important. We don't presume it is that important. But if you compare with your eyeglasses and you have dirty in your eyeglasses, you will feel that your vision has gone worse. But it's all because of this surface of your eyeglass that is not okay anymore. So it's about the same in tear film. You have to have a pristine tear film in order to have a good vision. And Visionix also gives me pupillometry, because pupil is also important in terms of light entering your eye and giving more quality of vision or not. Total aberrometry, internal aberrometry, metrics for quality of vision, for example, PSF and MTF. PSF being point spread function. What's point spread function? Which seems like complex, but it is not. It is how we see a point. Is it a point, just a point, or it's a blur? For example, this patient, he saw a car light, which should be a point of light, but you saw that he drew like halos and streaks. So PSF gives me this idea if he sees a point, just like a point or not. MTF is another concept that could be complex, but it is not. Complex is modular transfer functions. Visionix gives me that. What is modular transfer function? It's the relation that how much the optical system eats the quality of the image. For example, if I have an object here and I have a lens here, the image that will be formed will not use 100% of the image because sometimes something will be lost in the lens. So if 100% of information of this object comes to the lens, there is no way that 100% of this information will come to form the image. Something will be eaten by the lens. So this relationship, this number, the MTF, translates me how good or how bad a lens is. Every lens has a number of quality. So, for example, some intraocular lenses give me a better or worse MTF. So, maybe one patient with one lens, one intraocular lens, and the other with another intraocular lens, they can have different quality of vision because both of these lenses, they perform differently. They let more energy pass or not. So it's an important number, important information for me to understand the result I can give to the patient. Angle kappa, angle alpha. Currently, we use a lot of trifocal IOLs, for example, which they do have rings, and these rings have to remain in the center of the visual system, the visual axis. Sometimes, more often than not, some intraocular lenses, multifocal intraocular lenses that we implant, they do fall slightly off my visual axis. So the information that angle kappa or angle alpha gives me is how this center of the eye and the center of the vision is off or not. If a patient preoperatively has a high kappa angle, I know that maybe it's not suitable for diffractive IOL because the center of this IOL may fall outside the visual axis. Then, very importantly, toric planar and toric check. For patients with astigmatism, I can implant a toric IOL, and then I can not only plan with the equipment, but also I can check it afterwards. I can check with retro illumination as well to see if the lens is well implanted in the right axis. So, the Visionix has a very nice aberrometry system. We do have different concepts for aberrometry, like ray tracing, like rotating ischemoscopy. The ray tracing is, for example, in the eye trace equipment. The rotating ischemoscopy is on the OPD from NIDEC, and the Hartmann-Shack sensor is in the Visionix, in which we have a system of multiple lenslets that read the incoming rays that were emitted by the equipment, and then it reads the profile of these incoming rays to draw a map of aberrations. And this is the basic map. Visionix has several maps in order for you to assess the eye, but this is the main one. We can have, for example, it's very, very interesting because in just one screen, we can have it all. Pupillary distance, in this case, 65.5 millimeter. The refraction, you use your glasses, but it's interesting because Visionix gives me refraction depending on your pupil size. Sometimes it's very common for myopes to have worse vision at dusk. So why is that? Because you can have refraction, in this case it's not, but you can have refraction that is different in mesopic and scotopic situations. In this case, the measurements were in 2.9, 3.0 millimeter of pupil, and then in 3.5 millimeter. So one refractometer, regular one, does not provide me this information. And also, with some patients, they can complain of their vision during different settings. When I'm walking in the street and then I got in the tunnel, my vision is different. So this superior part of the screen can give me a hint of what's happening, and then I explain to the patient what's going on. The topography, as you click one of these maps, it's enlarged, but it's a very nice possible topographer. It also gives me the simulated keratometry with the average as well. It also has a shine through camera. It's not compared to the Pentacanal Galilei, but its shine through camera gives me the information of the anterior chamber. You can click on the image and it gets enlarged, but also you can have the pachymetry of the cornea as well. You have the tonometry. It's amazing because the equipment is like a robot. It moves and changes to the applanation, the puff tonometry, and gives me not only the tonometry, but it measures the cornea. It can gives me the corrected intraocular pressure compared to the cornea. It's important to correct the intraocular pressure, especially on those patients who had undergone refractive surgery and that they have thinner corneas and you have to correct the reading. So this is a basic overview of the system. So again, you have the refraction, you have the topography and keratometry, you have the shine field imaging with the pachymetry, tonometry, and as I mentioned, you can enlarge the information of the topography. And again, I have to stress out that it's very important. Although the Visionix VX120, 130, and VX650, they do have a barometer, which is very, very nice, but they do have a very, very well-constructed, well-built Placido topography. Placido topography is a deal breaker in terms of analyzing pre-op of cataract. For example, in this case, you can see the aspect of the cornea in terms of its morphology, but as well the numbers. You can have in the right eye, you have a cornea with very high numbers of keratometry, a very high astigmatism up to 9.25 of astigmatism. In the other eye, although it has some quite, I would say, nice numbers in terms of keratometry, you have low astigmatism in terms of the cylinder, but the map is not that good. You see that it's quite irregular. It also gives me in red some remarks for me to pay attention, especially when I'm planning a surgery. So my eye gets attracted by these red alarms, and it gives me automatically alerting me that this eye has, I would say, very high aberrations. So it's not a good case for premium IOLs. It gives me an overall glance on the patient's cataracts. I can just click in this screen and enlarge to show the patient his cataract. Maybe sometimes it's not that tangible for him to understand his cataract. So this retro illumination image shows the cataract, his cataract very well, and I can show off to the patient, and I can also grade the cataract based on these standards. It's interesting because I can also, for example, this is a retro illumination documentation of diffractive multifocal IOL. So we can see the rings here, and we can see from the shine through map how it is placed. We can see, for example, let me go back. If the patient has some problems in his posterior capsule as well because of the retro illumination, and then what is so interesting and so unique in this equipment, other equipments, they don't give this important information. For example, eye trace or OPD scan. The kappa angle, in degrees. Eye trace in OPD scan, they do give correlated information regarding kappa angle, but in micron. But actually, the real good information would be in degree. So Visionix is the only one here in yellow, the information of the kappa angle in degrees. So it's very important information for the surgeon who is planning to implant multifocal IOL, and then he can consider if the kappa angle of this patient is high or not. Amazingly, it's equipment that can assess the tear film as well, as I mentioned. So it's important for our cataract patients to have the most pristine vision because of these lenses. So the Visionix also gives the VX130 gives the map of the tear film. For example, in this patient, you can clearly see that some part of this cornea is suffering because there is some fluorescence being marked in his cornea, and we can also see in the breakup image that his tear film is not that good. So sometimes you have to plan before the surgery to treat his tear film in order to have a successful performance after the surgery. These are my cases. So these patients I treated before the surgery, and before he enters my office, I knew his problem because I received the report before he enters my office. So I have the whole information. I'm just confirming in the Solix lab. I can show off before and after treatment, and this is a great difference in the performance if I plan to make a surgery in this patient. One very nice thing in the VX is the aberrometry. This is the internal aberrometer, as I mentioned. Nowadays, we are in the golden age of aberrometry and cataract. These are aberrometries performed in post-op of my patients. I implanted these modern enhanced intraocular lenses, in this case, the Reiner EMV, and the Reiner EMV gives a nice vision to distance and a very good vision to intermediate. But how does it do that? It does by giving me distant vision in the center, which is in blue, and in orange and red, it's the near vision. It's peripupillary. So it's about the same in both eyes. And if you ask the patient, can you see to the distance vision? And he says, yes, I can, doctor. And you wonder, how can he see? And you can have a glimpse just by looking at his map. So the Visionix gives me this 3D perspective of the aberrometry, and I know that this IOL is performing well. But what is this importance? Because if the patient is satisfied, maybe I wouldn't need this image. But if you have the same patient and he could complain that the results is not that good, you could rely on the aberrometry in order to understand, well, does he have the distance and the intermediate vision in his eye or not? Aberrometry can answer that. So again, you can see the aberrometry in 3D in both cases. Again, a EMV Rayner intraocular lens, and in which it provides a distance vision in the center and an intermediate vision in the periphery. It's very clear. No other equipment gives me this kind of information. On the other hand, I can know how the patient is seeing. It simulates the vision of the patient as it collects the whole aberrometry, the pupil information, his cornea information. It takes all this information, all the data, and it makes a convolution. It makes like an analogy to his vision. So I can have his vision correlated to the letters, but also to the PSF. Look at this. His PSF. It simulates how he sees a point of light. It's not a point of light. It's spreading. So before he tells me, I can understand him, or I can trust him more, or not. I can assess his vision with the Visionix. Again, now I can see that this patient specifically, before he tells me he has a better vision, he sees very well. The point spread function is quite good. It's quite good. It's different from the previous patient. So I know that the quality of the vision of this patient is very good, and I can tell him before he points me out. And then there's this screen which seems to be complex, but I can guarantee it's not that complex. For example, this means that I can understand the quality of the vision of the patient with this simple graph. And how do I interpret this graph? Well, there's the curve. The green curve would be the optimal non-human optic system. There's no human with this green system. Our system is not that perfect. We lose something of the information of the image in our ocular system. So without correction in blue, without glasses, I lose much of the quality of the vision in both eyes. We can see this curved blue line, which translates me that it has low quality of vision. And I tell him, well, I'm going to give you a new pair of glasses, and the system, the Visionix, takes the information of the prescription you're about to give him and inputs in the current status of his eyes, and then it corrects his MTF information. So it's this yellow line, and it shows me that his quality of vision will improve in this yellow line after he uses his eyeglasses, his new eyeglasses. It's about the same in cataract surgery, in which we can assess if there will be an improvement in his vision after the cataract surgery. So it's a very elegant, very important information that seems like complex and very scientific, but it's very useful for a patient in the office. Well, I can tell you that this yellow line, which seems a little bit depressed, but it's quite the normal young quality of vision in humans. No one has, as I mentioned, this 100% of personal performance. There's a slight curve. As much as this curve is depressed, the quality of vision is worse. So Visionix is like having a very complex airplane, but now you don't fly in the blind. You have the full information in order to have the safest analysis pre-operatively and also assessing the performance after the surgery. So I used to use the Visionix to inform the patient. As you saw, it gives me a projection of how he sees a point, or how he sees the letters. I can show him, and I do show him. And patient gets impressed because he says, wow, that's the way I see the things. I use so many other informations regarding the pre-op planning and also for the post-op analysis, even in cases that were not that successful. For example, in this case, I have this map is very important. It's the reflection of the placido rings on the cornea. So by looking at this, I see that it has this patient has a very, very irregular cornea. If I implant a trifocal lens in this patient, it will be a mess because this cornea doesn't couple and doesn't talk very well with the trifocal IOL. So it's information that I have before the patient gets into my room. So important. He gets amazed because sometimes the patient enters my room and he says, oh, I want to use a trifocal IOL like a friend of mine, and I tell him, you cannot. How do you know that? Before I examine the patient, because this exam was performed before he enters the room. So again, I know I can tell him, oh, your surgery that you made a couple years ago or many years ago is now interfering with our planning. How do you know, doctor? Oh, I can see the scars or the cuts on the cornea that you have in both eyes. How did you see that? I have in my computer now. I know how bad you see. How do you know how I see, doctor? You didn't put me on the examining chair. I know how you see the letters. I know how you see the lights. Can I show you? And he points me. That's the way I see. Nobody knew. Nobody understood me. My complaints. Well, the machine does, and I do. So this is the kind of patient that in the beginning, when we didn't have this kind of tools, we didn't understand him. What is he drawing? What is this starburst when he sees? And you know, this patient is helping me. He's trying to help me. But now I can have, for example, the same information. This is a machine information. And this is the patient information. It's about the same. Just by assessing his eye with the computer can draw me the same as he tried to convey to me. It's impressive. It's impressive. Okay, I think it's actually it's a brief talk about the Visionix because I'm so excited to use aberrometry and all the tools that the Visionix provides to my patients before the surgery, as I showed. It's amazing to see the faces of the patients, and they never had this experience before. Whenever I show them the screens and displays of the Visionix and explain what they feel, they get amazed. They really do. And it's very important for them to understand what they have, for me to have the cooperation for the cataract planning. On the other hand, as I showed, it's an invaluable tool for the performance after the surgery. Sometimes you have poor results and you keep on guessing what happened. I have so many colleagues that felt trapped in some questions regarding, oh, I have implanted these IOLs and they're not successful. I don't know what I'm doing wrong. Well, that's why I say that this is the golden age of aberrometry. So I think Visionix is very well placed in this area. I really want to help doctors. I have a very great work in Latin America regarding teaching, and I love to help doctors and also distributors to bring this technology to the patients. I will make sure that I give Visionix some papers and some studies in order for you to have more information on how to use these resources to the doctors. And if you have any doctors in your area that want to know more about the Visionix and cataract workflow, please feel free to connect me to them. I will be more than glad to help. Thank you so much. Well, this I do have courses. Did we stop transmitting?
C'est quand vous voulez.
Bon, on est parti?
On est parti.
Good afternoon, everyone. My name is Adil El Maftouhi. I'm from Switzerland, Geneva, and Paris. And today I'm going to talk about the multimodality approach with the Solix platform. Solix platform is a spectral domain with a high sensitivity camera with a high rate of 120,000 scans per second with a very good axial resolution of 5 micron. The full range retina scan with 16 millimeters and 6 millimeters depth. The classic OCT angiography with a cube of 3x3 until 12x12 and the possibility to create a composite of 16 by 16 and a fundus camera of 45 degrees. So you can make some beautiful picture about the optic nerve, posterior pole, also anterior segment associated with your classic B-scan. The last evolution of the OCT using the full range technology embedded on the Solix platform and allowing the possibility to increase the depth using the mirror image until 6 millimeters depth. And also, therefore, with this large scan, you can highlight the scan of a myopic patient, highlight the visualization of the vitreous component with a beautiful visualization of the premacular bursa and Martigny area as compared to the conventional OCT with a small depth of 3 millimeters. And look here, the connection between the Martigny area and the premacular bursa. Another case here with a coloboma with a very large premacular bursa. You can highlight the area of Martigny. And look, you can have another modality with the OCT en face. You can image the two pockets of premacular bursa and Martigny area as compared to the scan. With the age, there is a connection with the premacular bursa and Martigny area. It's always difficult to analyze a dynamic tissue with a static approach. That's why I'm trying to give some dynamic approach with several consecutive B-scan. Look here, you can see the connection between premacular bursa and Martigny area. And with the PVD, you can also identify the connection with the posterior vitreal cortex and premacular bursa in case of vitreous liquefaction and PVD. And look here, another case of dynamic approach. You can distinguish the difference about liquefaction of the vitreous, the connection between the posterior vitreal cortex and the premacular bursa. You can also see the movie of the prevascular fiber in case of PVD. Another case of foveal traction with a full range retina. Also, this connection between the premacular bursa and the posterior cortex vitreous. And you can see also the reaction of the photoreceptor. With this very large scan, you can have some image about the interface in arcade area where you observe the first beginning PVD here with this schisis of posterior yellow-lid in PV. In a myopic patient with a very high depth, it's really easy to scan the patient as compared to the conventional OCT when you have a disturbance about the mirror image in this case. And look here, a dome-shaped macula. You can have the whole image in the window, acquisition window. You can also scan the peripheral area, and look here, we observe the beginning of retinal schisis, and you can move the fixation and scan the bullous retinal peripheral schisis in this patient with a fluorescent retina. You can also image some lesion like peripheral retinal details, and look here, you can see the hole and this retinal detachment. Another kind of lesion in case of inflammation in toxoplasma choroidititis, you observe also some punctuation within the vitreous due to the inflammation, in this case of toxoplasma. You can make a very quick screening of the retina with the retinal cube, and you can have also the ganglion cell layer, the retinal thickness, and you can cover the whole retina with a scan of 12 millimeters in just 5 seconds. And you have also a database for GCC. You can also associate vascular density. OCT angiography can perform very quickly with very high definition, and the main problem of in OCTA is to have a good compromise between high definition and time acquisition. And look here, with the Solix, you have a very dense B-scan within the cube, and you keep the information even with a large scan of 12 millimeters due to the scan density. And the scan density is the space between each B-scan, varying to 12 micron until 20 micron, and look at time acquisition 4 seconds until 50 seconds. And the specificity of OCTA for Optovue is algorithm, SADA algorithm, providing a very good contrast between the correlation signal and the background. And you can highlight the identification of the vascular plexus, capillaries within the RNFL, superficial plexus, intermedial deep plexus capillaries, and deep plexus capillaries with a very high definition according to the histology. And look here, with a cube of 12 by 12, you can easily identify CNV, in this case of a chronic CNC. You keep the information even with a very large scan. The projection artifact removal is really improved as compared to the XR with the Solix version to put off the projection artifact from the superficial plexus, inducing artifact in the deep plexus, in the choriocapillaries, and the Brooks membrane. And it's mandatory to have projection artifact removal to analyze the vascular density in the deep plexus. Look in this case of diabetic retinopathy. when you don't have power, and when you have power, you have a very good representation of your vascular density with this removal projection. And look, also in the chorial capillaries, you put off this artifact projection in order to better identify the presence of the CNV, of the decorrelation signal within the outer nuclear layer segmentation. And here we can compare with the OCT angiography overlay on the B-scan. And so we can isolate the decorrelation signal and to improve the follow-up of CNV. And look here, the CNV follow-up, and you can see very well the maturation of the vessel and the effect of anti-VEGF in the recent part of the CNV. With PAR, you can improve the sensitivity to CNV screening. In this case of incipient CNV, you look with PAR, you can isolate the decorrelation signal. Also, on the OCTA overlay on the B-scan, you can follow this patient 2 years after with the ingrowth of the CNV, but no exudation associated until 3 years after. And look here, the difference with B-scan. Here we observe a slight PED, but with no exudation. The segmentation in the Solix platform is really also improved, and you can correct the segmentation with the tool propagation. You can correct just one line, and you propagate the correction over the whole cube. And look here in this case of vascular speed. And after, we can better isolate the CNV decorrelation signal. The segmentation is really improved, and in the past, it was very difficult to identify CNV and PED due to the problem of the segmentation of the Brooks membrane and the segmentation of the RPE. And now, we really improve the segmentation of RPE and Brooks membrane thanks to the deep learning. And look here, automatic segmentation with no manipulation. You can highlight the presence of the CNV in OCT angiography, in this case of vascular PED. In another case, with no PAR, are associated with improved segmentation, and look the good visualization of the CNV. We can compare two generations of OCT. Look, in this case of vascular PED with XR advantage, and compare to the Solix. And look the difference of the segmentation. Now we can identify the CNV within the PED. Before, it was difficult due to the problem of the segmentation. So, improvement of the segmentation, improvement of the PAR software give a better visualization of neovascular flow associated with PED. Okay, this another very new pattern is a 3D volume rendering available just for the cube of 3 by 3 millimeters. And look, in this case of best disease complicated with the CNV, you can obtain the real shape of the CNV in 3 dimensions. And look here, the dome shape appearance of this CNV. Another case of CNV complicated McTail, and look here, in 3 dimensions, you can see the bad connection between the superficial plexus dilated with the intraretinal CNV. And look here, this connection with the capillary dilation directly in the CNV with the three dimension. And you can follow also this patient here with a two-dimension CT angiography, and in three-dimension we observe a very good vasoconstriction of the CNV after anti-VEGF therapy. Another case of CNV in case of a myopic patient. And look here, a very beautiful case of CNV type 4 to show the precise definition of OCTA embedded on Solix. And look here, we're going to move the slab through the retina, and you can highlight the abnormal connection between superficial vascular capillaries and the CNV. And look here, the decoration of the CNV. And you can see here the connection between two capillaries in the CNV. And you can zoom with no lose the definition. You have the possibility to have quantification for the CNV follow-up with flow surface, and the analysis of flow surface give the changes and the recurrence of the CNV when you observe an increase of flow surface, as is in case you observe a flow surface increase due to the recurrence of the CNV, and you can make a very precise monitoring in weight and another case with flow surface, and here is incipient CNV. You observe changes of flow surface due to thickening of anastomosis arcade before the first sign of exudation. And look, with this nice resolution and a nice signal, you can follow the patient during 2 years, and this patient keep the same visual acuity of 20/20, but we observe that the flow surface is not correlated with the visual acuity, and you observe maturation of the vessel. OCTA is very useful for the early detection with a very nice definition, like in this case of Dresden without fluid, and look in OCT angiography, you observe a very nice decorrelation signal corresponding to the CNV after the first sign of exudation. That's why now we can have a Dresden screening with OCTA, with a base scan, OCT angiography, and en-face OCT to check if there is incipient CNV. You can also check in case of pseudo-vitelliform deposit. Here there is no signal. Another case, we observe the fragmentation of the pseudo-vitelliform deposit a few months later, but base scan, you have some drusen, a little area of atrophy, thickening of Brooks membrane, but no fluid. But in the OCTA, we observe the presence of incipient CNV. And look here, after the first sign of exudation, we begin the treatment, and this is the follow-up of 3 years after anti-VEGF therapy. And you can obtain this movie due to the quality of the signal, and the flow surface demonstrates that we contain the surface of the lesion. Look here, the flow surface is 0.5, and after treatment is 0.48. The CNV is not always in weight IND, and sometimes you have CNV in chronic CSC or in a pachychoroid spectrum, and you have to use ENFAS to have a choroidal topography. This is an ENFAS OCT obtained by the OCT angiography cube of 12 by 12, and you can analyze the topography of the vessel. And look here, a pachychoroid spectrum in the left eye. And sometimes you can make a very good correlation between a small deposit in a pachychoroid pigment epitheliopathy and the area of choroidal dilation. Look, at the same area of the small lesion. And look here, you can observe the thinning of the choriocapillaris due to choroidal dilation, explaining the mechanism of pachychoroid. So, with one cube, you can have OCT angiography, the whole retinal thickness, and look here, we observe the thinning of the retina in the right eye. And look here, the dilation of the choroidal vessel in the same part, and we can make a comparison with ENFAS OCT. And in the same area, we observe a pigment epithelium disturbance in the same area. And look here with the thinning of the retina on this scan. And sometimes you can have pachychoroid associated with the CNV, and it's a game changer to make a good diagnosis, to give a good treatment, like a B therapy of anti-VEGF plus PDT. And look here, you can see a beautiful signal of the correlation. But here, the retinal cube, we observe a dilation of the choroid corresponding to the part of the pachychoroid spectrum, and the diagnosis was CNV in pachychoroid spectrum. OCTA in diabetic retinopathy, you can identify the capillary dropout, especially in the superficial plexus, the microaneurysm in the deep plexus, and we would like to follow the area of this capillary dropout in OCT angiography, and to check the presence or not of pre-retinal CNV, like in this case on OCT angiography, or in fluorescein angiography, the leakage was masked by the subretinal hemorrhage due to the motion of the hemorrhage. And look here, the CNV on the optic nerve, and you can make some composite to check the peripheral area. On the left side, you can observe the fluorescein angiography with the Optos. And look here, you can identify the presence of the preretinal CNV. And you can have the same visualization, but with a 3D rendering, and to isolate the presence of the CNV. Look, you can use the analytics tools to quantify the flow surface phase, the vascular density in the peripheral area, to follow the evolution of the avascular zone during the treatment. And look here, this is the 5 years follow-up of diabetic retinopathy. And the visual acuity still remain the same because the vascular density of the deep plexus continue to be pretty good, and we already know that the vascular density of the deep plexus is directly correlated with the visual acuity. And it's mandatory to have a trend analysis because when you perform OCT angiography, sometimes you have some variation of the signal due to the acquisition or disturbance of the opacities media, and this statistic trend is necessary to validate changes in vascular density due to the signal variation. And you can quantify the area of capillaries dropout and quantify the vascular density for superficial plexus and the deep plexus, and you can also check the peripheral area of capillary dropouts, like in this case of BRV. You can use also OCT angiography for inflammatory disease like acute multifocal placoid pigment encephalopathy. You can observe microvascular dropout within the choroid capillaries in OCTA as compared to the ICG, and to follow up this patient and look here after 1 month without treatment, you observe the resolution of this microvascular dropout. And look, with one cube, you have several multi-modalities. OCT A of 9x9, the deep plexus, outer nuclear layer, okay, no signal, choriocapillaries, very small disturbance due to the atrophy. And look here with an en-face OCT, you confirm the presence of reticular dystrophy. And the en-face OCT, we can see the area of atrophy with the same cube, and also the whole retinal thickness, and you can make your diagnosis with just one cube in few seconds. Another case here of the Combs dystrophy. You observe the thinning of the foveal avascular zone, and look here with the en-face OCT. We observe characteristic changes within the retina, especially in the outer nuclear layer. There is some change reflectivity with alteration of LPD complex. And look here, the B-scan corresponding. So you can use all information of the OCT, B-scan, en-face OCT, OCT angiography to give your diagnosis. Here the screening of nevus. You can check your nevus with OCT angiography, fundus camera, if there is a presence of fluid or not fluid, if there is a thickening of the lesion. In this case, the lesion is pretty plain, and you can make the measure of the surface directly on the base scan. Imaging with a very full range retinal, it's really easy with a large scan to make some scan of this lesion. Look here, in this case with a full range retinal. Solix Optovue is the first OCT who present a unique report combined structural OCT with RNFL, GCC, and the functional OCT with OCT angiography. We know with OCT angiography, you can quantify the radial peripapillary capillaries within the RNFL, superficial plexus within the ganglion cell layer, and deep complex within the inner nuclear layer. And we know that the nucleus of Miller cell is in the IOL. You can use en-face OCT to analyze the location of the defect. And look here, you can make a very good comparison with the GCC. And look here, the first beginning defect in the superior-temporal location, as compared with the normal shape of the RNFL. We know there is a good correlation between structural OCT and OCT-A, but currently we don't know what is the egg or the chicken. If there is on the beginning a functional defect before the structural damage. It still remains this question. But currently, we know there is a floor effect in the structural OCT, especially in advanced glaucoma. We know also that this floor effect is in OCT-A is less than as compared to the structural OCT. And probably we can use the OCT-A in advanced glaucoma associated with the whole retinal thickness in this kind of patient. And look here, this is a publication of Gabor Olo in a very advanced stage of glaucoma. And he compared the evolution with OCT angiography associated with the visual field evolution in this kind of patient. And it's the first time we have in one report the structural OCT and functional OCT. Here we observe GCC thinning with the beginning of thinning of RNFL compared with OCT angiography. Another case of the Lyme optic neuritis, you can see on en-face OCT the defect of RNFL on both eyes. Here you can have a trend analysis of the RNFL and also with OCT angiography. Here in optic neuropathy, in the tobacco alcohol, you observe the thinning around the GCC thinning around the foveal avascular zone, and you can make a correlation with visual field as the presence of a central scrotum. So, with retinal OCT, you can use B-scan, en-face OCT, angiography to make your diagnosis even in optic nerve analysis. So we can use the full range technology for the anterior segment, and the depth increase allowing the visualization of the whole anterior segment to make very easily a biometry with angle to angle, anterior chamber depth, crystalline lens rise, and wide to wide with a very wide scan of 18 millimeters with 6 millimeters depth. Now you can also have automatic biometry, and you can make a measure of wide to wide directly in infrared camera with a specific ring caliper. And look here, now is upcoming software with an automatic biometry, and you can use this information to help the choice of diameter ICL using the regression formula as the Nakamura formula, and you can predict also the bolting before the surgery. You can check the safe distance and the bolting in different conditions, photopic condition and scotopic condition, and to analyze the safe distance in artisan practical IOL, and the bolting in this case in hyperopic IOL. You can have the whole image of the crystalline lens, anterior crystalline up to the posterior capsule, to analyze the organization of the opacity. And here you can see conjunctival cataracts, contraction of the posterior capsule, and we know sometimes we can have some complication in this case. You can analyze IOL, the presence of PCO, or sometimes whitening and glistening. You can identify also the anterior yelloid and the visualization of anterior vitreous body. You can quantify the involvement of the crystalline lens rise in case of angle closer glaucoma. You can identify the scleral spurs, also the Schlenz scanner, and you can analyze the angle, in this case of gonius initial, concave iris in pigmentary dispersion, open angle and angle closer. You can check the iridotomy if it is non-transfixing or transfixing, and you can use also the 3D approach with the on-face OCT to check the iridotomy. And look here, in 5 seconds you can obtain this cube, and you can check the iridotomy to avoid the eye motion of the patient. Because when you use just one base scan, you are disturbed by the eye motion of the patient. If you can use the cube approach, it's really easy to check your iridotomy. You can analyze some conjunctival lesion, in this case of nevus. You can measure the nevus. And you can have a very high resolution of the cornea with a 5 micron. It's easily to identify the epithelium and the basal membrane of the epithelium in order to generate epithelium mapping. And now we have an epithelium mapping of 10 millimeters. In the beginning of the epithelium mapping, we had a 6 millimeters area of the mapping, but it wasn't enough to identify slight epithelium changes, especially in the area of 7 to 9 millimeters. And look here, the 9 millimeters, 10 millimeters, and you observe very slight changes in this area. And when you have a normalized epithelium mapping, you change the scale to 5 micron to 2 micron to highlight the slight changes. And with epithelium mapping, in the past, I propose a classification of the dry eye. In a normal eye, you have a uniform epithelium mapping. In the first stage, we observe an hyperplasia, suggesting an autoregulation mechanism between the epithelium and the tears. In the moderate stage of the dry eye, the lack of tear induces an increase of blinking frequency, inducing more friction between the eyelid and the epithelium, inducing a thinning of the upper part of the epithelium. And at the last stage, we observe the whole retinal thinning due to excessive pressure and probably also by the apoptosis process. In one of our publications in a British journal, we show a relevant statistic in the good correlation with breakup time and epithelium mapping. And we confirm also the tendency of the epithelium thinning in a more advanced dry eye. In the model mice, inducing after 7 days of the dry eye, we observe also an hyperplasia after 7 days. And the most likely hypothesis is the increase of pro-inflammatory cytokine is correlated by the cellular proliferation and can induce the hyperplasia of the epithelium. This hyperplasia occurred at the same location of the first rupture of the breakup time. And look here in the Nibud exam. The first rupture occurred at the same area of this hyperplasia. And look here, we observe in epithelium mapping a good stability of the information and this hyperplasia. We check with the en-face OCT, with the slab, the good thickness of the epithelium and confirm this hyperplasia correlated in this case of mammalian gland dysfunction. And look here, the correlation in case of incomplete blinking, we observe a very short breakup time correlated with the hyperplasia of the epithelium in the first stage of the dry eye with the advanced stage of mammalian dysfunction. And after the treatment, we observe normalization of epithelium shape with the increase of the breakup time. And now, with the Solix platform, you can have also the mammalian gland imaging and also the measure of the tear meniscus. And this is a case of different mammalian gland dysfunction with the atrophy of the mammalian gland. You can also use the color mode to analyze the inflammation of the blepharitis. And you can make a good correlation between epithelium mapping and mammalian gland imaging. And look in this case of a young boy of 11 years old, we observe MGD grade 1 associated with hyperplasia in the inferior part of epithelium thickness and associated with a normal thickness of the stroma. You can also identify the mammalian stagnant due to the incomplete bleeding with the en-face OCT. You can use also en-face OCT to distinguish the lipid component in this instability during the dry eye. And look here, some different cases about the instability of this lipid component. So it takes sense that OCT may play an important role on multimodal dry eye screening with epithelium mapping, the measure of the tear meniscus and mammalian gland imaging, and also with en-face OCT. And look, in this case, we observe an important instability of the lipid component. This instability is more pronounced in the left eye, and we observe also a more pronounced thinning of the epithelium on the left eye. That's why We can talk about the multimodality approach also for the anterior segment. And look here, this is a biomicroscopy picture with the presence of keratitis, en face OCT, and the epithelium mapping. With epithelium mapping, you can follow the dry eye patient after the treatment. And look here, during the treatment, we observe the improvement of the epithelium mapping according to the subjective improvement. Before and after IPL, look the improvement of the epithelium mapping. Another case, before and after IPL, in very advanced neighboring gland dysfunction. And look here, you observe telangiectasia. This is before IPL, this is after IPL. You observe a reduction of this telangiectasia. Another case of more advanced stage of the dry eye. And look here with the incomplete blinking, scleral show, chalazion. This is before and after the treatment. And look here, we observe also a reduction of the fault of conjunctival chalasis after the treatment. And you can also analyze this dynamic approach with OCT B-scan, with a vertical scan. You can see very well this conjunctival chalasis. OCT en face can bring quantification of this flow. And look here, a case of patient with history of LASIK and PKR. We observe here a scleral show. We know after the LASIK and PKR, you can observe an hyperplasia of epithelium. And look here, before the treatment and after the treatment, you observe normalization of the epithelium shape. And it still remains a question, what is the role and the involvement of the ocular software disorder in case of refractive regression after refractive surgery? It still remains this question. And probably in the future, we can analyze the eye drop persistence with epithelium mapping and en face OCT. And look here, when you make an eye drop installation, we increase the epithelium thickening and you measure the time to go back to the normal. And look here, this is a B-scan appearance, and probably we can use the OCT in the future probably in the pharmacologic study. You can have a very good information for the refractive to analyze the flap diameters before the new refractive surgery. You can measure the flap and the residual stromal bed very easily, even several years after. And you can use en face OCT to analyze the cutting shape of the LASIK. And look here, you can see very well the cutting shape of the LASIK. With en face OCT, you can move through the cornea to analyze the complication of the LASIK. And look here, this is a microfold within the flap inducing diffraction called the Baguini effect. And this is the drawing performed by the patient. A case of smile, look at the right eye, there is a very regular cutting shape. This is an incision and the cutting intrastromal cutting shape. And look here, there is a problem of docking and still remain a piece of lenticle with a reflectivity in the interface. And look, the epithelium mapping. The epithelium mapping change also with with the scale, with the stroma, epithelial mapping can change due to the curvature changes also. Another case of epithelium ingrowth in the smile procedure. And look here, you can see the epithelium ingrowth with the convex OCT. You can make a correlation with the epithelium mapping and look at the area of epithelium ingrowth. You observe epithelium thinning in this area. Another case of complication of LASIK after the new surgery. Look here, this is the first cutting. The second cutting, this is a microflow within the flap. The epithelium ingrowth, and this is the entry of the epithelial ingrowth and the B-scan corresponding. In PRK, you can see very well the aids thanks to the high resolution of the Solix, and you can make the merger to identify the location of this opacity, and you can you can make also the screening and the assessment of the refractive regression. Look, in this case, patient treated for -8 diopters. You observe a very slight epithelium hyperplasia, but it's pretty normal. But we observe a small opacity inducing in this myopia. And also, epimapping can be useful for the keratoconus screening. Dan Russian was the first to describe this aspect with the thinning of the epithelium above the cone associated with hyperplasia dullness. And look here, so this shape with the thinning above the cone associated with the dullness hyperplasia, and you have always to compare epithelial mapping with a stromal mapping to confirm this aspect. And look here, these changes was more pronounced in the left side, and you can confirm with the corneal topography. And this is a new display of pachymetry with total pachymetry, stromal pachymetry, and epithelium pachymetry together to make a very good comparison each other. And another cases of keratoconus in epithelium mapping, the right eye you have thinning of epithelium associated with hyperplasia, but on the left eye you observe first keratoconus, but you have a complete hyperplasia. It's epithelium reaction due to the dry eye. That's why you have to compare always epithelium mapping with stromal mapping. And look here, the stromal mapping on the left side, you observe a decentered aspect of the stromal mapping and the sealing of the stroma, confirming the presence of this first keratoconus. And you have always to compare if you have an hyperplasia just due to the dry eye, this is a normal stroma, or if you have epithelium changes and stromal changes confirming the presence or not of keratoconus. And for refractive surgery now, it's completely mandatory to compare corneal topography with epithelium mapping. In this case, it is a patient with a history of grass allergy. You have a beautiful meibomian gland dysfunction, more pronounced on the right eye, and you observe an hyperplasia in the inferior part on both eyes, inducing curvature changes, producing asymmetry in corneal topography. That's why now you will have a corneal topography on the Solix platform to have a better comparison between the corneal topography and epithelium mapping. We showed a good correlation with other topographer of the market with a good quantification. And look here, you can make a comparison with epithelium mapping. In this case of keratoconus, you observe the ceiling of epithelium above the cone. But it's always is also useful to detect some curvature changes due to ocular surface, and this is the case of hyperplasia. And look, in the same area, you have curvature changes inducing asymmetric of the corneal topography. In other cases, with hyperplasia, and look, in this case, the stromal is completely normal. And look, here the projection of the hyperplasia directly on the corneal topography. That's why it's mandatory to compare corneal topography with epithelium mapping and the stromal mapping. And look, we know hyperplasia can occur also in the curvature changes, and look, in this case of intracorneal ring in emphasis OCT, and you observe also hyperplasia above intracorneal ring. With the emphasis OCT, you can check the position of intracorneal ring in the whole surface of the ring. You can also check the contact lens fitting and the clearance of the scleral lens. And look here, there is a contact between the lens and the keratoconus. And you can use also emphasis OCT and epithelium mapping to manage some corneal disease like adenovirus keratoconjunctivitis. We know it's a long resorption for this conjunctivitis, and you observe here, after the cyclosporine treatment, the improvement of the ocular surface and the reduction of the nummular aspect of the lesion until the complete disappearance of the nummular aspect and the complete resorption, complete normalization of epithelium shape. And this is the follow-up with the upcoming software and the trend analysis of the epithelium thickness, and you observe the improvement of the thickness of epithelium. You can analyze the surface of Cogan dystrophy, and this is a microflow of the basal membrane, and sometimes you have some changes always associated with dry eyes in this eye condition. And look here with the emphasis OCT. We can move through the cornea and you can see this microflow of the basal membrane with very large view as compared to the confocal microscopy. Another case with a geographic aspect of the Cogan dystrophy. In case of cornea guttata, in B-scan, 2 dimension, you observe a very small hyperreflective punctuation. In emphasis OCT, you observe dark spot due to the dysmetic guttata as compared to the specular microscopy. And now we can have a multimodal approach for the scare screening with the emphasis OCT, and you can measure the lesion with the B-scan. Here, another case of cornea verticillata, you have an aspect of the epithelium changes in this lesion. In B-scan, you observe a pseudo double aspect of the bovine membrane, very pathognomonic about this corneal lesion. And look here, the high resolution of the cornea with the Solix. And you can also control the interface of the graph, the penetrating keratoplasty, and of society you can see the scale of the penetrating keratoplasty. The video doesn't work. So it takes sense that Solix is a multi-modality approach with en-face OCT, OCT on geography, B-scan, corneal topography, mammalian gland imaging for retinal, glaucoma, cornea, dry eye screening, and refractive surgery. And thank you for your attention. Do you have Solix?
We have. I mean, I'm actually a company. We are distributed for, but owner of this company also have